here.
Got it.
I'm not Members, we need a couple of more minutes because the time clock is not working and we need. Good to go? Yep. Okay. Okay. The Subcommittee on Health will now come to order. Good morning, colleagues. Good morning, Mr. Secretary. Welcome. Due to COVID-19, today's hearing is being held remotely as well as in person. For members taking part remotely, microphones will be set on mute to eliminate background noise. Members will need to unmute their microphones when you wish to speak. Since members are participating from different locations at today's hearing, recognition of members for questions will be in the order of subcommittee seniority. Documents for the record should be sent to Megan Mullen at the email address we've provided to your staff, and all documents will be entered into the record at the conclusion of the hearing. Secretary Becerra has a hard stop at 1:15 p.m. today, so you will find that I will not be my usual generous self in terms of not lowering the gavel after 5 minutes is consumed. So we want to have enough time for every member to question. So the chair now recognizes herself for 5 minutes for an opening statement. Mr. Secretary, welcome to your first in-person hearing with our Health Subcommittee. What a difference a year makes. When you last testified at our subcommittee in May 2021, our hearings were virtual. The vaccine rollout was just beginning, and Congress had just passed the American Rescue Plan a few weeks before. Today, over 218 million Americans are fully vaccinated. COVID hospitalizations and ICU admissions are at the lowest they've been during the pandemic. Premiums under the Affordable Care Act are at an all-time low, and enrollment is at an all-time high. Nearly 6 million Americans have newly gained health insurance coverage over the past year, and American families have saved an average of $2,400 on their ACA health insurance premiums last year. President Biden's fiscal 2023 budget request continues these achievements by helping American families rebuild from the COVID-19 crisis healthier and safer than before. The budget invests $81.7 billion over 5 years in pandemic preparedness, including $40 billion for the development and manufacturing of vaccines, tests, and treatments, and $28 billion to rebuild the CDC and the public health workforce. These are incredible figures. Importantly, the budget provides $11 billion to address the overdose crisis, and every member of this subcommittee, Mr. Secretary, is engaged and care deeply about this issue. President Biden has called for a whole-of-government approach to save lives, get people the evidence-based care they need, and go after drug traffickers to stop overdose deaths. The president's budget outlines a strategy to use $20.8 billion to improve our nation's mental health, including increasing the availability of crisis care and achieving full parity. This is so important, and achieving full parity between physical and mental health care coverage. The budget continues to focus on addressing health disparities. It invests in quality maternal health care, especially for Black and Native women, while also increasing funding for the Title IX Family Planning Program. It takes the historic step of proposing $142 billion over the next decade in mandatory funding. This is a first for the Indian Health Services. Importantly, the President's request provides $5 billion in the Advanced Research Projects Agency for Health, ARPA-H, which holds the potential for transformational, advanced biomedical research to address diseases like Alzheimer's, diabetes, cancer, and ALS. As the House sponsor of the authorizing legislation for ARPA-H, I believe your decision to place ARPA-H within NIH, let's just put it this way, I don't agree. That's in capital letters with exclamation points. There's still more to do. We still need a safe and effective vaccine for children under the age of 5. We need to make sure that vulnerable Americans' health insurance coverage is not disrupted when the public health emergency expires. We have to continue the health insurance subsidies from the American Rescue Plan. And we must finally allow Medicare to directly negotiate drug prices so that prescription drugs are affordable. So I look forward to working with you to develop a budget and policies to improve our nation's health and well-being. And we thank you for being here with us today, Mr. Secretary. The chair now recognizes Mr. Guthrie, our distinguished ranking member of our subcommittee, for 5 minutes for his opening statement.
Thank you. Thank you, Madam Chair. Thank you, Mr. Secretary, for being here today. And today we're discussing the U.S. Department of Health and Human Services proposed fiscal year 2023 budget. Today also marks just the second time that the Secretary has been before this subcommittee, and when the Biden administration has extended the public health emergency 5 times. And we should hear more from our leaders of an agency that controls over $1 trillion in spending, and I call on my Democratic colleagues to hold more HHS oversight hearings. It's one of the most important duties that we as members of Congress have, and our constituents deserve better. One stark example is the lack of oversight on COVID-19 spending and response. The last time the administration testified on COVID-19 before the committee was in March of 2021, over a year ago. I know myself and other members of this committee have asked Secretary Becerra to provide a detailed plan for unwinding the COVID-19 public health emergency, and particularly how agencies intends on ensuring there are no significant disruptions as we transition from these blank waivers as they expire. And we've yet to receive a response, and hopefully we will do so soon. Oversight is especially important given the huge increases in funding requested by the Biden administration. The HHS budget before us today calls for a 12% increase in discretionary spending at HHS for fiscal year 2023. The budget specifically gives more than $6 billion combined boost in funding to the Centers for Disease Control and National Institutes of Health, both of which have come under fire recently over controversial mask guidance and COVID-19 research funded by NIH using American taxpayer dollars. We need to hold NIH accountable. We need to also ensure taxpayer dollars are not going to labs engaging in risky gain-of-function research, and ensure researchers are transparent about how they're spending taxpayer dollars from these funded research grants. The budget even increases spending for climate change initiatives at HHS, and through the 174-page budget that we have here, it mentions climate change more than fentanyl. I am increasingly concerned that HHS has lost its way since President Biden took office, and these budget priorities reflect this change in course. HHS has become increasingly more politicized, which we saw with CDC school reopening and masking guidance, and less transparent with Congress, especially in the context of the use of COVID-19 relief funding that a recent Stat News article outlines. The agency has also taken a punitive one-size-fits-all approach to combating COVID-19 through onerous vaccine mandates. The Biden administration has always failed the American people by planning to revoke Title 42, which was used to prohibit migrants from entering the United States illegally to prevent the spread of COVID-19. This poor decision comes despite the Biden administration extending the public health emergency for another 90 days in the same month without providing a clear plan of action to address what many expect will be a massive influx of migrants trying to enter the United States through our southern border. We have seen an unprecedented level of fentanyl and fentanyl-related substances entering our country through the southern border and killing thousands of Americans. Between 2020 and 2021 fiscal years combined, U.S. Customs and Border Patrol seized over 15,000 pounds of illicit fentanyl at our southwest border. This coincided with the highest number of drug overdoses our country has ever experienced, and the expected number of overdose deaths reaching 106,000 in the 12-month period ending in November 2021. We need to secure our borders and work to permanently schedule fentanyl-related substances to keep these poisons out of our communities. We can also do this while promoting public health programming, like the bill Mr. Tonko and I partnered on together. This legislation offers individuals seeking help overcoming their addiction with the resources they need to get back on their feet, like workforce services and peer support services. I finally am concerned with the department has continued to restrict access to proven medical advances, such as the first FDA-approved therapy to treat Alzheimer's disease in almost 20 years. Urge the Biden administration to swiftly repropose a new coverage policy that allows patients, doctors, and their families to make informed decisions about their treatment. HHS must get back on track to using its resources for solutions that will drive down healthcare costs for Americans, keep deadly drugs off our streets, and bring new breakthrough and potential life-saving cures to patients. Thank you, and I yield back.
Gentleman yields back. The chair now recognizes the chairman of the full committee, Mr. Pallone, for his 5 minutes opening.
Thank you, Chairwoman Esho, and let me thank our former colleague and secretary for being here today for this important hearing. I'm pleased to have you here to talk about the budget, because the budget is really an expression of our values, and the annual budget process provides us with an opportunity to review and consider the priorities of the administration. That's why I'm pleased this budget proposal puts resources towards the programs and agencies that help improve lives, prepare us for the future, and protect the health and well-being of all Americans. The funding priorities in this budget provide a roadmap to continue to get back on track in the wake of the pandemic, to keep fighting COVID-19, continue making healthcare more affordable and accessible for all Americans, to improve our country's response to mental health challenges, and to address deep and persistent health inequities. The impact and ongoing response to COVID-19 has helped to crystallize the importance of adequately funding public health, and I'm pleased the budget makes critical investments in our public health infrastructure to ensure the federal government has the resources it needs, and the budget increases funding for each of the agencies within HHS that are involved in pandemic response. And the work of these agencies has allowed Americans to return to a semblance of normalcy. I'm immensely proud of the Biden administration's work to undertake the largest free vaccine program in our country's history, and as a result of their efforts, 3 out of 4 Americans have received at least 1 dose of the vaccine, and this has reduced hospitalizations and healthcare spending, and most importantly, saved millions of lives. We're also in the midst of a mental health and substance use disorder crisis, and our country continues to be devastated by overdoses driven by the widespread availability of opioids and stimulants in the drug supply, such as fentanyl and methamphetamines. And I'm glad to see that the budget prioritizes funding for programs and services to address this and acknowledges a connection between mental health and substance use. The budget increases access to prevention, harm reduction, treatment, and recovery services. Each of these are critical components to effectively address substance use. Now, without question, the Biden administration's actions have dramatically improved access to health insurance coverage. And I want to commend Secretary Becerra for the tremendous progress HHS has made in helping people get affordable, high-quality health care. During the 2022 open enrollment period, a historic 14.5 million people enrolled in health care coverage. Because of the success of the American Rescue Plan, families have seen lower premiums, and the national uninsured rate is near historic lows. Despite these gains, there are still significant gaps in the healthcare safety net in the states that continue to refuse to expand Medicaid. Closing the coverage gap for uninsured people remains a priority, and the House has taken action to ensure that low-income Americans in every state will have access to quality, affordable health care. I'm also pleased the budget prioritizes investments in health equity across HHS, including funding for a number of critical maternal health programs that will reduce inequities that have long persisted in maternal health occurrences. And finally, the budget also reiterates the Biden administration's commitment to reducing prescription drug prices and calls on Congress to pass legislation that aligns with the principles included in the administration's comprehensive plan for addressing high drug prices. Americans pay, on average, 3 to 4 times more for the same drug as those in other countries, and we continue to watch drug prices increase year after year as our constituents struggle to afford the medications they need to stay healthy. This House has taken action to give the Secretary of HHS the ability to negotiate for lower drug prices, cap out-of-pocket costs in Medicare Part D, and stop drug price increases at the rate of inflation. So it's imperative that these policies become law as soon as possible. And I'm pleased that President Biden shares our commitment to reducing drug costs and saving American consumers money. So let me thank you, Javier, for being here today. I look forward to hearing from you on the administration's priorities and certainly appreciate your and HHS's ongoing work to ensure the health and well-being of the American people. Thanks again, and I yield back, Madam Chair.
The gentleman yields back. The chair is pleased to recognize the ranking member of our full committee, Congresswoman Cathy McMorris Rodgers, for your 5 minutes opening statement.
Thank you, Madam Chair. And Mr. Secretary, welcome back to the Energy and Commerce Committee. This is an important day, and we have important questions that need to be answered. Health and Human Services has been at the forefront of the COVID-19 response. You have jurisdiction over CDC, NIH, and many other agencies. And unfortunately, we've seen too many examples where Health and Human Services seems to prioritize what is an extreme political agenda rather than staying focused on mission. The mission is to improve the health and well-being of all Americans. I'm very concerned about a lack of transparency that is eroding people's trust in public health and eroding confidence in Health and Human Services. First, there's the administration's confusing response when it comes to the public health emergency. The administration's decision-making hasn't been based on science. What we see more and more is that it's based upon power and politics. President Biden wants to lift Title 42 for a radical open border agenda, despite an overdose crisis that is killing more than 100,000 people a year, mainly because of illicit fentanyl coming across the southern border. According to President Biden, there's no COVID-19 emergency for illegal immigrants, but there is for toddlers in Head Start who are still forced to wear a mask. Student loans are still being deferred, costing taxpayers $4.3 billion per month and making the inflation crisis worse. We see the administration fighting to keep the mask on for those that are traveling on airplanes. None of this appears to be rooted in common sense, science, or an awareness of the crises in America today. People want their freedom back. This is the land of the free. They want a secure border, a healthier future for their children, safer communities, and they want leadership that reflects these priorities. We're not in the same place we were 2 years ago, and that is why in February, I asked for the administration's plan to properly unwind the public health emergency, and I've yet to receive a response. I also want to discuss the Centers for Medicare and Medicaid Services' unprecedented decision to restrict coverage for an FDA-approved Alzheimer's treatment to only 1,300 to 1,500 people fortunate enough to have been in the clinical trial. Worse yet, this decision applies not only to the recently approved drug Aduhelm, but an entire class of Alzheimer's treatments. We should trust doctors and patients to decide if an FDA-approved drug is right for them. FDA determined the drug is safe and effective, including for seniors in the Medicare program. This decision is clear second-guessing of FDA's authority to determine drug safety. Democrats may say that the drug would bankrupt Medicare, but it's hard to take that concern seriously when Democrats voted for using savings from their government drug price control proposal to subsidize and inflate health insurance premiums for people not on Medicare. I urge that this proposal not be resurrected and that you rethink the national coverage decision. There's also other examples of how the department is losing the public's trust. Inflation from out-of-control government spending is making everything more expensive, including health care and for seniors on fixed income. Seniors are now paying 15% more, the largest dollar increase in program's history. Yet bipartisan laws signed by President Trump to lower costs remain unimplemented and unenforced. We're still waiting for the rules to make it easier for people to know what doctors are in network, and we haven't seen enforcement against hospitals refusing to post their prices. Yet we've seen other top priorities, millions of dollars for a climate change office, forcing healthcare workers to perform abortions on demand, policing speech with big tech companies, price controls for fewer cures, colluding with teachers' union to keep the schools closed and kids masked, undermining the rights of parents, avoiding oversight for how taxpayer dollars are spent on risky research in China, and again, the open borders instead of cracking down on fentanyl trafficking. This is not inspiring confidence. My message to Health and Human Services today is to stop digging the hole. Let's build trust. Let's make sure that we are trusting people to make the best decisions for themselves and their families. Our mission is to improve people's well-being. And with that, Mr. Chairman, Madam Chairman, I yield back.
A gentlewoman yields back. I will now introduce our witness. Secretary Javier Becerra is the 25th Secretary of Health and Human Services in our nation. Previously, he served as the Attorney General of the great state of California. And very importantly, he served 12 terms in the House of Representatives, and we are classmates. We entered the Congress together. So welcome back, Mr. Secretary, to the subcommittee. You're now recognized for your time to provide your testimony to us.
Chairwoman Eshoo, great to see you again. Ranking Member Guthrie, good to see you also. And thank you again for the time you've made available to have conversations in the past. To all the members of the committee, thank you for this opportunity to discuss the President's FY 2023 budget for the Department of Health and Human Services. Today, more than 257 million Americans have received at least one dose of a COVID-19 vaccine. 2/3 of adults over the age of 65 have gotten a booster shot. We've also closed the glaring gap in vaccine rates we usually see for communities often left behind. It has paid dividends to surge resources, including tests and treatments, to our hardest hit and highest risk communities. 340 million free COVID-19 at-home tests shipped across America, 270 million free N95 masks, 100 million booster doses, almost $186 billion in provider relief funds distributed through more than 800,000 payments to over 441,000 providers for COVID losses and expenses. That's 441,000 hospitals, community health centers, doctors, pharmacies, nursing homes, and so many other healthcare providers. Real money, real relief, real results. Beyond COVID-19, today more Americans have insurance for their healthcare than ever before in the history of our nation. That includes a record-breaking 14.5 million Americans who secured health insurance through the Affordable Care Act. Many of those insured Americans are paying less than $10 a month in premiums for that solid insurance coverage and the peace of mind that comes with it. In addition, we launched Operation Allies Welcome, an HHS-led effort that has helped over 68,000 of our Afghan brothers and sisters resettle as refugees in America. And we have now begun to extend support to Ukrainian refugees fleeing the Russian invasion of their homeland. We're coordinating with our 50 states, tribal governments, and territories nearly $300 million in nationwide support to prepare for the launch of the new 3-digit 988 National Suicide Prevention Lifeline this July. What 911 is for local emergencies, we're working hard to make 988 for Americans experiencing a mental or behavioral health crises. HHS has also made key investments to close holes in our public health system in areas like maternal health, where we've extended Medicaid coverage for postpartum care for a new mother and her baby from 2 months to 12 months. The President's 2023 budget lets us build on that record of investment in Americans' health. It proposes $127 billion in discretionary budget authority and $1.7 trillion in mandatory funding, including a standout and historic investment to transform the mental health infrastructure in our country, a priority I know you share. It also asked for $82 billion for the President's pandemic preparedness proposal to get ready for whatever might come next after COVID-19. Considering that COVID has cost our country more than $4.5 trillion in direct support from the federal government so far, this is a no-brainer to prepare for the next pandemic. The funding we're requesting will be end-to-end, meaning for research, development, approvals, deployment, and effective response. Madam Chair and members of the committee, this budget turns hardship into hope, inclusion into opportunity. I look forward to working with you to make it a reality and to continue our efforts to give Americans real relief, real results, and real peace of mind. With that, I'm more than willing to answer any questions you may have.
Thank you, Mr. Secretary. We'll now move to member questions, and the chair recognizes herself for 5 minutes to do so. First, Mr. Secretary, we know that we don't agree with, or I don't agree with your decision relative to ARPA-H, but here are my 2 questions very quickly on it. You've explained that by placing it in NIH, it was necessary to do so so that the administrative work of standing up the agency could take place. My question is precisely how much time does ARPA-H need NIH's administrative support to get stood up? Just very quickly.
Madam Chair, we're going to use NIH to make sure that those ministerial duties.
I know. How much time?
We'll wait to make sure that we get a director in place to find out exactly how much that director
So you don't know how much time yet?
No, because we have to make sure that the new director has the ability
Okay.
to make some of those
Can ARPA-H, in your view, be an independent, standalone agency once it is stood up?
It will be an agency that has its own authorities and its own direction and its own director that will report directly to me.
I think I just got the answer. Political reports that FDA may wait to receive both Moderna and Pfizer's vaccine applications for children under 5 before beginning the authorization process. But Moderna's vaccine application may be ready before Pfizer's. Is it true that FDA plans to wait for both applications? I mean, obviously, parents across the country are their patience is strained.
The FDA is waiting to receive that information from both of those manufacturers, and as soon as it has the information, it will move through the process of trying to find out if it is safe and effective.
So is FDA waiting for both applications?
It still has not received the full applications from either one.
Okay. The COVID response, back to the budget, the COVID response under the Trump administration, I think, was really marked by a great deal of chaos. The strategic national stockpile was empty. Local public health departments were overwhelmed. It took far too long to get tests and treatments to the public. In May of 2020, our subcommittee heard from former BARDA director Rick Bright about how he and his agency were marginalized and ignored when he pushed to develop critical COVID treatments and increase production of masks and other equipment. Under your leadership, BARDA is empowered to respond to COVID and future pandemics. My question to you is, BARDA's budget is continually rated to fund other HHS efforts. If Congress provides the new pandemic preparedness funding, will you commit that BARDA will not see its funding transferred to other agencies? These are very important funds. The Strategic National Stockpile has its own funding, $975 million. $828 billion with a $80 million increase to BARDA. But if the figures are only markings on a sheet of paper, what needs to benefit the American people is not going to take place. So I think my overall arching question, Mr. Secretary, is the following. Are you changing course, and if so, how, in terms of pandemic preparedness? We've learned many lessons. It's so important for us to demonstrate that we've learned the lessons of the past and not just pile on more money to more programs. So can you just spend a moment to describe where the changes are and also your commitment to BARDA?
Madam Chair, thank you for the question. I won't speak for previous treatments of BARDA, but what I will tell you is, as you see in our budget, we call for a 10% increase in its budget. BARDA will be one of the chief proponents of the President's Pandemic Preparedness Plan moving forward. The work that is being done through HCOR, which is the operation that took over from Operation Warp Speed, relies on BARDA. From my perspective, we can't get out of this pandemic without BARDA. And we're going to do everything we can to lift up BARDA because it is the agency that Congress created to help us navigate those minefields.
I like your description of BARDA. I'm very proud that it was my legislation that created it. So I think at some point, Mr. Secretary, that you give an overall view, perhaps today, if not in writing, what is going to change. And the new dollars that the increases that are infused in the overall agency. With that, the chair now recognizes the ranking member to question for 5 minutes.
Thank you. Welcome back to the House, Mr. Secretary. Glad to have you here today. I toured the border early in the year with Dr. Burgess, and the border was overwhelmed. My focus was for this subject of this committee was the illicit fentanyl coming across the border. And when we were talking to the Border Patrol, and Dr. Burgess asked the question, and he said that what if we repealed Title 42, revoked it? And he said it would go from a crisis to a catastrophe. And so the concern is when CDC, HHS recommended, I know it's tied up in court now, but did recommend removing this May 23rd, did you consider the flow of illicit fentanyl coming to the country and what countermeasures you know this would create another opportunity for it to come forward? What was the concern when you made that decision about fentanyl? 70% of Kentuckians who died of overdose died of illicit fentanyl. I think that's typical for most of our states. So in revoking the decision to revoke Title 42, what factors did you put into place for fentanyl or other drugs coming across our border?
Congressman, first, I think we all recognize that we need to do everything when it comes to drug enforcement policy to make sure we interdict drugs that are trying to come into the country. But you're confusing health policy with migration and drug interdiction policy because Title 42 would impact those immigrants who are actually crossing the border and not trying to clandestinely enter. They're trying to seek asylum. So when they come in, they present themselves. Therefore, if they were carrying fentanyl, we'd be able to discover.
So we asked that question though of the Border Patrol, and what they said was anything that doesn't discourage people from coming, the volume continues to increase. And therefore, matter of fact, we went through one of the processing centers, and they said, look at every person in here with a badge, every person in here with a uniform, and that's somebody that should be on the border. So understand Title 42. I'm not confusing it. But I do know that it is a deterrent, that if you're going to remove that deterrent, I know HHS has a different focus than Homeland Security, but surely the administration has some kind of plan in place to try to interdict this illicit fentanyl that is flowing across the border.
And again, Title 42 speaks to health conditions in the country. And what you're speaking to are either migration challenges or drug interdiction challenges. And
right,
so
but it's still a country challenge. I understand.
That's correct, but you would use migration laws or drug interdiction laws to try to deal with those challenges, not healthcare laws.
So on the illicit fentanyl, currently it's temporarily scheduled. Do you think it should be permanently scheduled, illicit fentanyl, and subject to mandatory minimums?
On fentanyl, what I can tell you is that the FDA and the different agencies within HHS will be reviewing how we treat, whether it's fentanyl or any other drug, whether we put it on any formularies.
Okay, but you're not going to take a position whether it should be scheduled?
I wouldn't want to get ahead of the agencies that actually do this through the science.
All right, and so we talked a little yesterday. I remember last Thanksgiving trying to go around town in Bowling Green, Kentucky, trying to find tests for my kids thought that they might have brought COVID into our, not fentanyl, thank goodness, COVID into
Hopefully
our,
they didn't find that. Yeah.
our community. And you know, And there was just a shortage. Kentucky had to ration monoclonal antibodies for Delta, and the vice president said, we didn't see Delta coming. I think most scientists did not, upon whose advice and direction we have relief, didn't see Delta coming. And every time we had Dr. Fauci, we said, we're going to get out of masks, we're going to do this. He goes, well, we don't know if a wave's coming. It seems like we didn't know a wave. We expected a wave to come and weren't prepared for it. Could you talk about why we didn't have, we're talking about all the, if you remember all the press conferences in April and May of 2020 when the previous administration was there, everybody was testing, all the other things. And within 3 months, we're a year and a half into it and we weren't ready for a wave.
Congressman, thanks for the question. And as we discussed previously, we had millions of tests available. What happened is that Americans started to demand the at-home tests. The tests that we had available were the tests that would take a week or two to get results because they go into laboratories to give you the results. People wanted immediate results because they wanted to know if they could go visit their grandmother.
Exactly.
So what we did was we really ramped up the availability of those instantaneous at-home tests, which unfortunately are less reliable than the PCR tests.
Why weren't we ready in November of 2021?
I'm sorry, where?
I understand what you're saying, and the president set up the program where people can order these tests.
Yeah.
But why weren't we ready in November of 2021? We
Well,
didn't know it was going to come that month, but we knew a wave was coming, and we just didn't have the at-home tests.
Well, remember, we had hundreds of millions of tests available for Americans as of the summer. In fact, we had no tests available for the American public a year ago, or about February, March of last year. So we ramped up dramatically, but the shift came when people wanted to be able to take the test solely at home. Very convenient.
And then we didn't
less
have enough
reliable.
antibodies either. I know my time has expired, but thank you for your time. I appreciate you being here.
Gentleman yields back. Chair is pleased to recognize the chairman of the full committee, Mr. Pallone, to question for 5 minutes.
Thank you, Chairwoman Eshoo, and thank you, Secretary Becerra, for your testimony. I wrote a provision in the Families First Coronavirus Response Act in March of 2020 that provided states with an increase to their federal Medicaid funding if they agreed to keep everyone enrolled in Medicaid during the public health emergency, and every state took the deal, and it's been a tremendous success at ensuring that poor and disabled Americans didn't lose their health insurance during the pandemic. Now, when the public health emergency ends, states have to check that everyone on their rolls is still eligible for Medicaid. But I'm worried that people could be wrongly dropped from Medicaid simply because they make a procedural mistake during the application process. Now, the Centers for Medicare and Medicaid Services recently released guidance that promoted 12 months continuous eligibility for children under Medicaid, 12 months postpartum eligibility for new moms with Medicaid, and CHIP express lane eligibility. And these policies could help mitigate coverage losses after the public emergency ends. So I was glad to see CMS endorse these policies because, as I'm sure you know, the Build Back Better Act would actually require every state to put in place the continuous coverage policies that I just mentioned and would permanently authorize express lane eligibility. So my question after that long intro is, it seems critical that Congress passes into law these policies to ensure that children and new mothers will keep their coverage when the public health emergency ends. And I just want you to say whether you agree. You don't have to just say yes or no, though. You can expand.
Chairman, the results are there. It is clear that by having provided that kind of coverage, extended coverage, we have kept Americans from falling into the poverty crack. And I hope that Congress is able to work together to continue that support because today, as I mentioned, more Americans have health care coverage. Fewer Americans are living in poverty than before.
Well, thanks. Now, the Tri-Caucus chairs recently sent a letter to House and Senate leadership asking for these policies to be included in the final reconciliation legislation. And I wanted to thank Representative Ruiz and Representative Kelly for their leadership on these issues and their letter. The letter states that Black and Latino individuals and certain Asian American populations are disproportionately covered by Medicaid, and it stands to reason that these individuals would therefore be at greater risk for coverage losses at the end of the public health emergency. So my second question, given these concerns, it seems that the continuous coverage provisions in the Build Back Better would help prevent disproportionate coverage losses amongst minority groups and are important for health equity. Do you agree with that?
Absolutely. And we know that there are some 12 to perhaps 15 million Americans who might lose their insurance coverage if we don't do the Medicare expansion and continuous coverage the right way. And so we hope that in this process of unwinding from the public health emergency, we don't lose all those Americans who are currently getting covered.
Well, thank you. Now, finally, Medicaid covers about half of the children in the country now and pays for nearly half of all births. So these coverage provisions are not only far-reaching, but they're affordable. And as you know, we paid for them entirely in the House legislation. So my question is, given the low cost of these policies and the huge number of children and new mothers they would cover, it seems like they give us a tremendous bang for our buck. And that's my final question, whether you agree.
As my mother would say, mejor prevenir que remediar, better to prevent than to remediate. You did a phenomenal job of helping us prevent illness and disease, which makes it possible for families to have healthier children who become healthier leaders of our country in the future.
Well, I appreciate that. You know, I think everyone on this committee knows that prevention saves money, but as you know, because you were on the Ways and Means Committee, that's not the way the CBO works, right? They charge us for everything, whether it prevents further costs down the line. But I think we have to constantly remind everyone that prevention does save money, and I appreciate what you said. So I don't know, it just seems obvious to me that if we want to ensure that children and new mothers don't lose their Medicaid when the public health emergency ends, that we should include these coverage policies in the legislation before the public health emergency ends. So thank you again. I yield back. Thank you, Madam Chair.
The gentleman yields back. The chair is pleased to recognize the ranking member of the full committee, Representative McMorris Rodgers, for your 5 minutes to question.
Thank you, Madam Chair. Mr. Secretary, in February, I asked you and the President for a plan to end the public health emergency, hoping to get information about how to transition 2 vaccines fully approved to commercial distribution and how states can quickly and easily incorporate flexibilities from the pandemic into their Medicaid programs. We didn't receive a response or your plan, but we have received more requests for money. These requests have come without information on how you and the states have spent pandemic funds to inform needs today. I'll note the reports about COVID-19 funds going to fund things like high-end hotel, a ballpark, and ski slopes. Do you commit to following up on your current budget request and also more funding requests to include all assumptions about operations, cases, and relevant existing available funds to all members of Congress and the public?
Congresswoman, we will continue to provide the information that outlines how we have used the COVID money that we've received. We've provided volumes of paper in response to questions. We have done numerous briefings, bipartisan briefings on the expenditures for COVID. We'll continue to do that. The President's plan to move us beyond COVID-19 but stay prepared for any future pandemic outlines in his budget how we would use the money. We're more than ready to brief you as well in more detail because we know we need to be ready.
Yes, well, it's pretty basic, and we need to have those details, and unfortunately, there's a lot of questions that have not been answered. Do you anticipate the U.S. government being the sole purchaser of COVID-19 vaccines for the rest of 2022?
We know that there are other, whether it's nations or there are others who are looking to purchase. We will continue to make sure that we provide the American people with the supply that we need, and so we'll do everything possible to make sure.
Do you have a
we
projected
secure what we
cost?
need. I'm sorry?
Do you have a projected cost to the federal government?
The pandemic preparedness plan does outline what we think we would need. Remember that if we're talking about getting further supplies of existing vaccines, that would be a different price than if we have to go towards a vaccine that deals with new variants, or if we have to go toward a new vaccine altogether.
Do you have a plan to transition to commercial distribution for vaccines?
That is part of the President's pandemic preparedness plan.
Okay, thank you. I asked last year if there would be any proposals that would give you as Secretary the ability to implement drug price controls using quality-adjusted life years, QALYs. QALYs put a price on a person's life, and the National Council of Disability has recommended against using QALYs. I'm introducing a bill this week to ban the use of QALYs. Do any proposals in the budget require your department to rely on QALYs to make decisions?
Congresswoman, the best I can tell you is right now, nothing that we are proposing would put any limits on the ability of an American to be able to get the best quality care that America can afford to provide.
Does your department use QALYs?
I'm not aware of our particular agencies using anything like that to make final determinations.
Well, I'm pleased to hear that. I hope that you'll look at my legislation. I think it's very important that we clarify and ban the use of QALYs. Finally, because of inflation and surging prices, Americans are paying more for everything, including health care. Empowering them with information on the actual price of health care is more important than ever. Your budget states that, quote, enforcement activities are necessary to drive compliance with price transparency. A recent survey found a majority of hospitals are not compliant with the hospital transparency rule. When will we start to see these enforcement actions?
Congressman, we have begun enforcing that law as of this year. We have issued numerous challenges to some of the providers where we have evidence that they are not following through with the transparency requirements under the law. Fortunately, most of those providers are responding in kind to make adjustments, and we will continue to enforce that law.
Well, I appreciate your commitment to this. I believe it is so important that we're getting this information, and really this is something that has been supported bipartisan, Republicans and Democrats coming together and making sure that we do have this transparency around prices.
Agree.
And finally, I just want to say, as it relates to the budget, it's been disappointing. We've been a bit frustrated that we haven't seen more details on how funds have been spent, but I did notice that you had found the resources to establish an Office of Climate Change and Health Equity in August of 2021. And I also just saw this past Friday released an initiative to lower hospital emissions. I just hope that you will get back to the priorities that have been outlined in a bipartisan way. I yield back, Madam Chair.
Gentlewoman yields back. Chair is pleased to recognize the gentleman from North Carolina, Mr. Butterfield, for your 5 minutes to question.
Thank you very much, Madam Chair, and thank you, Mr. Secretary, for your testimony today. It's good to see you, Mr. Secretary. I have great memories of our work when you served here in Congress. Even have great memories of our travel when you served with us in this body. I particularly remember when we accompanied President Obama to Charleston for the funeral of the Charleston Nine, and so I appreciate your friendship and appreciate your work. Over the years, Mr. Secretary, I've been really alarmed about the growing mental health and substance abuse disorder crisis facing our families. I'm very grateful that the administration has taken action to address the growing mental health and substance abuse disorders. In the midst of COVID, Congress provided nearly $9 billion to states and to tribes and communities to respond to emergency mental health and substance use needs through the appropriations, through the CARES Act and the American Rescue Plan. The 23 budget would build on those efforts, providing $2.9 billion for mental health, $6.6 billion for prevention and treatment efforts within the Substance Abuse and Mental Health Services Administration. My question is, what activities and communities does the administration intend to target with these increased resources, and why?
Congressman, first, thank you for the earlier mention of the friendship, and I hope to continue to work with you on any number of these subjects, but certainly on this one, because the President has made it clear he intends to deploy game-changing resources and investments to make sure we tackle the mental health and behavioral health crisis. I mentioned the 988 lifeline that we hope to launch in mid-July that will let anyone who's suffering a mental or behavioral health crisis to be able to reach to someone who can offer them help. We're going to do much more when it comes to drug overdose problems that we've seen. When over 100,000 Americans are dying in 1 year from drug overdose, we know we have to tackle the opioid and drug overdose crisis. And we're going to do everything we can to help children, because we know COVID has exposed the belly of what we see as a true problem with mental health being experienced by our youngest Americans. And so we're going to do everything we can to focus on that. I'm engaged right now in a national tour, visiting states throughout the country to try to highlight what the President is hoping to do in his budget.
Thank you, Mr. Secretary. Let me just ask you this. Let me ask you about the proposed crisis care set aside and the prevention and early intervention set aside in the mental health block grant, as well as the proposed recovery support services set aside in the substance abuse block grant. Why do you believe these programs are important, and can they have flexibility to meet the needs of our citizens?
Congressman, as I said earlier, prevention is far better and more effective and better for the dollar than is remediation. If you wait till someone has a real crisis, it costs a lot more money, just like going into an emergency room, than it does in trying to prevent someone from getting to the point of suffering a crisis. So we want to interdict where possible. We want to intervene where we can. And what we want to do is let families know that we want to be their shoulder to shoulder with them as they try to address these crises, especially for these children.
Thank you. I have time for one more, Mr. Secretary. Since 2015, I've worked on a bipartisan basis to expand access to disposable wound therapy for Medicare patients receiving home health care. In 2015, we successfully created a new Medicare benefit to this effect. Unfortunately, the way this benefit was implemented makes it extremely difficult for patients to access this technology. To fix this, Mr. Mullen and I introduced legislation that would make technical corrections. Would you be so kind as to commit to work with us on this proposal so that it can make it to the president's desk before the end of this Congress?
You have my commitment, Congressman, to work with you to see where we can go with the legislation.
Thank you, Secretary Becerra. I yield back, Madam Chair.
Gentleman yields back. Chair is pleased to recognize the gentleman from Michigan, Mr. Upton, for your 5 minutes to question.
Thank you, Madam Chair, and welcome, Mr. Secretary. We're glad to have you in person today. That is for sure. And I want to thank you, Chair, for holding this important hearing and your leadership on ARPA H. I'd like to think that we're close to moving bipartisan authorizing legislation through this committee. And I would note that my Cures 2.0 partner, Diana DeGette, and I look forward to working with you to advance this important legislation as well. We also look forward to working with you and Chairman Pallone and ranking members Cathy, McMorris, Rodgers on another important bipartisan piece of legislation. Cures 2.0, we continue to hear from patients, families, doctors, researchers, innovators from across the country how important it is to move forward. This committee works together. We do improve America's lives, and I'm thankful to be part of it. Simply put, patients can't wait, and we have no time to waste. So, Mr. Secretary, drug-resistant bacteria now kills more folks than HIV globally. Sad statistic. CDC is reporting that both drug-resistant bacteria and fungi are on the rise because of COVID. The Pasteur Act, bipartisan bill that we included in 21st Century Cures 2.0, is urgently needed solution to these growing threats. You agree, I think, with the need to address the AMR and fungi threats as well, and I'd appreciate your thoughts on the Pasteur Act as a solution.
Congressman, let me just first say thank you for tackling this, because too many people are not aware of how rapidly we're losing the ability to use antibiotics to treat what are pretty common diseases and illnesses. And it's not affecting just us, but it's worldwide. And unfortunately, as you know, it is tough to get the manufacturing sector to jump on this because there's not a lot of money that they can make anymore. And so we have to work to provide the incentive. So I am absolutely supportive of the efforts that you are making in this, because AMR, antimicrobial resistance, is a problem not just in developing countries, but here in the U.S.
So I'm also deeply concerned about, thank you. I'm also deeply concerned about the state of federal health insurance programs like Medicare. In my view, Medicare's antiquated approaches to coverage are not well suited for cutting-edge technologies that have the potential to transform care. Some have pointed to the issue of improving FDA CMS communications on innovative technologies that might help CMS better cover and, more importantly, reimburse for them. Unfortunately, it seems like the administration might be moving in the wrong direction with its decision to pull the MCIT rule. So can you tell me or share with me your thoughts on improving the CMS FDA communications and what we might expect with regards to the MCIT rule?
Once again, you ask a critical question, because technology has taken this to a new place. There was a joint statement recently issued by both the heads of the FDA and CMS to make clear how it's important that these two distinct agencies work together where they can, but still fulfill their separate, distinct missions as well as possible. And we're going to run into these circumstances, as you mentioned, more and more often because technology is taking us farther and farther towards getting new treatments and therapies. What I can tell you is that so long as the mission of FDA is to make sure that there is a safe and effective treatment or drug available to the Americans, that is critical. And at the same time, we have to make sure that CMS's role, which is different, it is more an issue of whether that particular therapy or drug is necessary, is the real issue that we have to confront. But I believe that with that joint statement of the two heads of these agencies, they made it very clear they're going to, where possible, make sure we're working together.
Well, thank you. I yield back.
Gentleman yields back, and I want to reiterate once again, as I have previously, my fullest support for Cures 2.0. I believe that is a must for our subcommittee to advance and the full committee, as well as ARPA-H authorizing language. And I salute you and Congresswoman DeGette for the work that you've done. We're all in your debt because you've been working on this for 3 years, and the culmination of that will be what the subcommittee does with it. The chair is pleased to recognize the gentlewoman from Florida, Ms. Castor, for your 5 minutes to question.
Well, thank you, Madam Chair, and welcome, Secretary Becerra. It's great to see you. And I want to thank you and President Biden for successfully lowering health care costs and premiums for millions of American families. That is what Democrats in Congress intended through the American Rescue Plan. And now high-quality coverage is more affordable and available to families at a time when they really needed to put money back into their pocket. 14.5 million Americans now rely on the Affordable Care Act. And it has been a particular godsend in my home state of Florida, where we're the third largest state in the country, but we have the highest enrollment of any state, 2.8 million Americans now. That's a 28% increase over last year, largely because we were focused on lowering their costs through those enhanced tax credits. Can you briefly discuss the impact of the American Rescue Plan and what it has meant, what those enhanced tax credits have meant for affordable health care coverage? How many new individuals signed up because of those tax credits, and how many, what's the scope, and what do you predict the future holds?
Congresswoman, thank you. By the way, thank you very much for the work you did to make sure that the Affordable Care Act could be there and that we could have the American Rescue Plan to make even better the results of good quality health care available to so many Americans. You mentioned it with the numbers. Americans are speaking with their feet and with their voices in applying for these health care plans. The fact that today 14.5 million Americans can rely on health insurance because of the Affordable Care Act. 6 million of them new to the program altogether. And as you mentioned, several million in Florida by itself, one of 50 states. The fact that we can offer, as a result of your work on the American Rescue Plan, Americans a health insurance plan of quality, not a junk insurance plan, but of quality for $10 or less a month in premiums. You can't even go see a movie today for $10 or less for one movie, let alone a full month of health insurance coverage. That's real peace of mind.
It is. In the grocery store, in church, everywhere I go in my home state, they really are grateful. I mean, this came at a time we were dealing with a pandemic, and a time when costs are really hammering our families. So thank you for everything that you've done. You must take great pride in the fact you were here when we passed it, and you're there when you see the expanded coverage of these high-quality plans. I also had some sad news from a friend last week who was just diagnosed with an HPV-related cancer. And I'm so grateful that President Biden is there to help reinvigorate the cancer moonshot. And what you've included in your budget related to trying to save American lives and lower costs again by expanding the HPV vaccine really deserves kudos. This is the first time it showed up explicitly in the budget. And I'd say, you know, when that vaccine wasn't around when we were younger, but it is now for for kids and adolescents. And what I've learned back home is when you ask parents, if you could prevent your child from ever contracting cancer, would you? And of course they would. And here we have this safe and effective vaccine that's been available since 2006, but the uptake rates are not high enough. So talk to me about, you've committed now to do more on HPV. How does the department plan to use what you've identified as $5 million to expand efforts to improve coverage, and what can Congress be doing? We did pass a bipartisan bill out of this committee, by the way, and a bill through the House of Representatives that will help, but what is your plan?
Congressman, one of the things we learned with the Affordable Care Act and the enrollment, the record-breaking enrollment numbers, and with vaccines and reaching communities that are often left behind today, you have Black Americans, Latino Americans who are vaccinated at essentially the same rate as white Americans. A year ago, there was a dramatically disparate difference. And what I will tell you is that what we found is that if you go to people, instead of waiting for them to come to you, they latch on. They take up the effort. And so when it comes to HPV vaccine, other treatments that we know are effective, we're going to go to those communities to let them know about this. Because if, as you said, if they know, they'll make sure their kids get these vaccines.
Thank you very much. I yield back my time.
Gentlewoman yields back. Chair is pleased to recognize the former chairman of our subcommittee and one of our doctors, Dr. Burgess of Texas, for your 5 minutes to question.
I thank the chair, and let me just start by saying I do want to associate myself with the remarks of our ranking member of the full committee, Ranking Member McMorris Rodgers. I do feel one of the really severe casualties of this pandemic has been the credibility in our public trust, the public trust in our public health institutions, and we really do need to work to regain that. And when you see it almost daily. I guess on the good news front, Dr. Fauci was on Judy Woodruff last night and pronounced the pandemic over. So congratulations. I somehow missed it in the headlines this morning, but I'm glad that is, at least I hope that is true. And I also want to associate myself with the remarks of the chairwoman of the subcommittee on ARPA-H. It's a critically important authorization that this committee needs to undertake, and I share her concern about it being co-located on the campus of the National Institute of Health. So, Secretary Becerra, you'll remember the last time we spoke was in our budget committee hearing across the way, and I was concerned about funding for gain-of-function research, particularly in adversarial countries. You disagreed with me, and you said, I think that question has been answered before, and you didn't think it would be true. I still remain concerned about it. I remain unconvinced that NIH did not have some role in this funding. So I promised you some articles supporting my position. I've asked that, Madam Chair, that we make those part of the record today, and I will, at the conclusion of this hearing, I will get those to you. But even if we disagree about NIH funding gain-of-function research in an adversarial country, really the point is made over and over again in those documents that this was all done in a BSL-2 lab. The biosafety level of the Wuhan lab was not a biosafety level 3 or 4, as I think it should have been, but it's almost like it's asking for a lab leak if you're dealing with a pathogen such as this in a BSL-2 lab. So I guess the question is, are we at a point now where we will be very careful about where we fund this type of research? It bothers me that it was in an adversarial country, and it really bothers me it was in a BSL-2 lab.
Dr. Burgess, first, let me just say that much of what you said I agree with. We should always be very cognizant of how any gain-of-function research is done. We should be very cognizant of where it's done for all the reasons you mentioned. And I think that what I can do is assure you that at the NIH, at the Department of Health and Human Services, we take those same concerns and admonitions that you've just stated very seriously. But I would agree with you that we have to be very, very careful because who knows what can surface as a result of some of this research that's done, especially if it's done in a place that's not equipped to really handle it.
Well, I really do hope that you will provide the committee with the official HHS policy directing the NIH in this regard. We had a hearing on mental health, and I appreciate your comments on mental health. A couple of weeks ago, I brought up, are you familiar with what's referred to as the IMD exclusion, the Institute for Mental Disease exclusion that prevents Medicaid from paying for coverage, hospital coverage? So I brought up a concern about that, and I asked the HRSA administrator if that was a barrier to getting care, and she wasn't really, she said there's some challenges there, but I didn't get the impression that really she put that as an obstacle to care. So let me just ask you, do you think the IMD exclusion is a barrier for patients getting the mental health treatment that they need?
Congressman, I think we're seeing the growing need for health care, and Medicaid has become a place that Americans have been able to rely upon to help them pay for their mental health care services. IMD does impose a restriction. I believe it's a statutory restriction that makes it tough for Medicaid to cover mental health services in many cases. We are more than willing to work with you and your colleagues to try to make sure that Americans are able to secure the type of health care, even if it's for mental health, not just regular health, that we need.
Well, I tried to add that as an amendment when we were doing one of the reconciliation bills. It was defeated on a party line vote. I hope I can look to your help when bringing that forward again in legislative language, because I agree with you, it's a legislative fix that is required. And it is expensive, I grant that it is, but it's the old thing about pay me now, pay me later. What is the cost of doing nothing? And I think we found it to be extremely high. Thank you for your testimony today. I'll yield back.
Look forward to working with you on that.
Gentleman yields back. Chair is pleased to recognize the gentleman from Maryland, Mr. Sarbanes, to question for 5 minutes.
Thank you very much, Madam Chair. Secretary Becerra, welcome. I appreciate the work that's gone into this budget proposal. It's very much, for the most part, I think, a lessons learned budget. It really looks at what we've been through and tries to reposition us in a visionary way for the future. So I thank you for your efforts and the efforts of your staff. The pandemic, as we know, has taken a really heavy toll on healthcare providers, public health workers. That's obvious. And these frontline heroes have been very stressed, very overburdened during the crisis. Many have left the workforce, as we know. And we also know that a strong, well-trained workforce in the health field is critical to supporting a high-quality delivery system. And we have to make data-driven decisions about how to prioritize the workforce. To that end, I know the agency, your agency currently has a number of initiatives in the health workforce space, including this National Center for Health Workforce Analysis, and I support that effort. Could you describe the work of the center just a little bit and how you see the FY23 budget request responding to this need for collecting, analyzing, and ultimately acting on workforce shortages and related challenges?
Congressman, thank you for your interest and all of the work that you've done over the years on these issues. I think a lot of working Americans appreciate what you're trying to do. The National Center for Health Workforce Analysis conducts research. It tries to help us determine if there's a sufficiency of the workforce throughout the country, the geographical distribution, what the level of education is for the workforce. Essentially, it tries to inform you, policymakers, about where the gaps are, where the deficiencies are, so you can better target your resources to make sure that if one region of the country lacks a certain type of healthcare professional, nurses, for example, that we're able to make sure we target it appropriately. So this way we spend every dollar that we have most efficiently to make sure we boost up the workforce.
I think it's going to be very important to do the analysis carefully because in addition to there being a lot of competition among healthcare providers for those workforce positions, there's also going to be competition between the healthcare industry and other folks that are looking for workers. There's a lot of teacher vacancies, for example, across the country, et cetera. So we've got a real labor workforce potential challenge coming at us, and navigating that with some good, strong data review and analysis is going to be important. I certainly support this center. I'm hoping my colleagues in the House Appropriations Committee will even double the funding for the center to make sure that we're in a position to handle this challenge working together and moving forward. Let me turn to another topic real quick. We talked about this last time you were here. It's school-based health centers. I think all the evidence is when you have these resources in place with a captive audience, which is a school full of children that need support and help and health care for themselves, and oftentimes connected to their families and their communities. It makes a huge, huge difference. And I'm happy to see that HHS has been making strong investments in the health and well-being of our nation's children, including through recently announced joint initiatives between HHS and the Department of Education to expand health services in schools. Can you talk a little bit about the HHS commitment here to supporting school-based health centers and the students that they serve in this coming year, including through the initiative that I just mentioned? I mean, if I had my way, there would be a full health suite in every school in America. It seems kind of like a no-brainer when you think of all the good that could do. So I'd love to hear your thoughts about that.
Congressman, maybe you are younger than me, but I remember when I was going to school, in elementary school, there was a nurse at our school. Today, you find a nurse in an elementary school, you're very fortunate. It is one of the major losses that we've seen over the years in trying to provide our children with as much access to health care, especially for kids who have parents who can't afford insurance. It's a big loss that we've seen over the years. The president has made a commitment to try to reach out to communities to provide health services to children, including at school-based settings. We are providing $40 million for a new pilot program to integrate behavioral health supports in a community setting. So whether it's in a school, community centers, somewhere where it's accessible to families where they don't have to travel a long distance. We'd like to continue to work with you and others to see if we can build up programs like Project Aware, which is a program that helps us focus resources and attention into places like schools so that our children do have access to care when oftentimes they don't have access otherwise.
Thanks very much. Look forward to working with you and others in the department. Yield back.
Gentleman's time has expired. Chair is pleased to recognize the gentleman from Virginia, Mr. Griffith, for your 5 minutes to question.
Thank you very much, Madam Chair. Secretary Becerra, Ranking Member Rodgers, Subcommittee Ranking Member Guthrie, and myself have sent numerous questions on COVID origins to the NIH. Can you please get them to answer, yes or no?
I'm sorry, what's the question?
Will you get the NIH to answer our questions in relationship to COVID origins?
Congressman, I know that the NIH has answered
yes or no?
many of the questions that have been asked on
If you can give me a more detailed answer later, I would appreciate it. I got a lot of questions to ask in a short period of time, as you are familiar. Last June, after visiting the border, I asked Acting Assistant Secretary of the Administration for Children and Families whether the Office of Refugee and Resettlement, ORR, needed additional authority or resources from Congress to improve the inadequate process of vetting potential sponsors of unaccompanied children. And what they're telling the American people is that they're doing background checks. And what they're doing is they're doing a background check on a computer that's not part of the criminal background system in our country. They're just checking, people finders or been verified, that kind of thing. Not adequate. I got a written response stating, quote, ORR is currently in conversations with our agency partners to determine what additional authority or resources are needed from Congress in order to improve the sponsor vetting process, but nothing further. In the meantime, unaccompanied children continue to arrive in the U.S. ORR continues to place children with sponsors with no real background check. If we were doing this in a custody case, and I used to practice that kind of law, either the attorneys or the judge would be in front of somebody trying to figure out why they didn't do a proper background check. So have you taken any action to improve the vetting process for unaccompanied minors and there's truly unvetted sponsors, yes or no? And I understand you may have to get back to me. Can you get back to me with a full written answer on that? Because I'm very concerned about this. Because while I don't think they should be here, if they're going to be here, let's make sure we're putting them with safe people. I will continue with another question and expect a full answer. Can you get me an answer? I do need something affirmative in.
Well, I can tell you I don't agree with the way you posed the question, but I will provide you with an answer to try to give you as best information I can.
And I appreciate that. And I just, look, most of that I stated the facts. We might disagree on whether they should be here or not, but the facts are they aren't doing a proper vetting process. And if our court systems were doing this, there would be people in trouble with the public. All right, I'm going to go back to another question.
On the particular issue of vetting, that's where I disagree with you, but we will respond to your questions.
We're going to have to continue to disagree on that because it's just plain poor. All right, last year you and I discussed the fact that President Biden had instructed agencies to maximize the use of goods, products, and materials produced in the United States. I hope you're making plans to refill the strategic national stockpile. American manufacturers stand ready to provide supplies. Will you commit to ensuring products that your agencies buy come from manufacturers whose operations are in the U.S.? Yes or no?
340 million free at-home test shipped, 270 million free N95 masks. We have done what we need to do to make sure we have a stockpile that can.
But are they American manufactured? Because we got lots of people out here who are saying they're going to go out of business because we're buying from the Chinese again.
And by the way, because of the instruction given by Congress, we have more authorities to make sure domestically manufactured products are available and in that
and we'll give you whatever you need on that, I'm sure.
Look forward to working with you.
Last week, I joined my colleagues, Cathy, McMorris, Rodgers, and Brett Guthrie in sending you a letter with some questions about troubling increase in deaths associated with substance use disorder. Will you commit to getting us a timely response, a complete timely response on that question, on those questions? And I know you probably haven't seen it, but if you can give us a timely response, it would be greatly appreciated, say June 1st, June 15th.
Congressman, we're committed to try to respond as quickly as we can, and please let's be in touch if you haven't gotten the responses you need.
I appreciate that. We will be. In its response to a March 8th letter I sent to SAMHSA, it stated that it is not and has no plans for conducting, collaborating, or funding studies about the mental health impact of the pandemic. Do you not agree that the institution responsible for overseeing our nation's mental health should be involved in such work? Yes or no?
Okay, I'm not sure I understood because SAMHSA is absolutely engaged in trying to make sure we are assessing the needs throughout the country for mental health services.
Well, that's not what they told me. I'll send you a copy of the letter. All right, last but not least, when it comes to treating patients with substance use disorder, it is critical that 42 CFR Part 2 be revised to better align with HIPAA regulations. The CARES Act instructed Substance Abuse and Mental Health Services Administration, SAMHSA, to do so with a deadline of March 2021. These regulations have yet to be published. Earlier this month, I asked your colleague, Dr. Delphine Rittmond, for a status update. She was unable to provide it. Can you?
Congressman, you threw a lot of numbers, code sections at me. Without a further reference, it'd be hard for me to respond.
All right, and I do appreciate that, and that's why I said I had to move quick because I had a lot of questions in a lot of big areas, and these are not simple questions. I will get you a written question, but I really would like a response on that because we're a year behind what the law says you all were supposed to do. I yield back.
We'll follow up.
Gentleman yields back. Chair is pleased to recognize the gentleman from Vermont, Mr. Welch.
Thank you very much. Mr. Secretary, it is so good to see you and welcome. Really is. I'm going to ask you in about three different topics: DIR fees, drug pricing, which you've been a long time champion of, and also a substance abuse treatment program in Vermont that I think has broad applicability. First of all, on the DIR fees, it's really brutal what's happening to the cost of drugs that gets passed on to seniors and also to our community pharmacies. And I'm someone who thinks that the community pharmacies are an essential component in our healthcare system. And I know your agency is looking at the DIR rule in an effort to change it. It would save about $20 billion in out-of-pocket drug costs for folks who are on the Part D program. My hope is that the rule will be finalized without delay for the year 2023. By the way, this has got a lot of bipartisan support here in this committee. So my question is, where do we stand on that, Mr. Secretary, and can we have confidence that we will get this done this year?
Congressman, good to see you, and thank you for the question, important question. We agree with you. It's an important rule. We're working it as quickly as we can. I can't give you a specific timeline as I can't give you too many specifics, but we understand how important it is because patients' costs are at stake, and we want to make sure that no one's paying more than they should for the drugs and medicines and treatments that they need.
Well, let me just emphasize, this has been a tug of war for a number of years. The insurers are pushing back, pushing hard, and this is about whether it's their profits or we're going to get fair pricing, and it's also about fairness to our community pharmacies. I mean, they really have this bizarre situation, as you know, where they sell the product at the stated price, and they get a letter from the pharmacy benefit manager saying, oh, by the way, that product you sold at the price we agreed on 3 months ago, we were just kidding, and you owe us money. I mean, can that at all be justified as a business model? Seriously.
Congressman, we're in the midst of rulemaking, and you know it would be inappropriate for me to respond to questions that go to the substance.
All right, well, I hope you heard my plea here. Again, bipartisan.
I remember hearing it for many, many years, and it's a good message.
In drug pricing, again, I acknowledge your role you've played when you served here, and of course in your role as Attorney General in California. So I know you're totally committed to doing everything you can to get price negotiation. I know the administration is. That's part of Build Back Better. Where are we on this? I mean, folks are paying huge amounts for everything from insulin to life-saving medication, and the drug industry is just unrelenting and using its pricing power, and they're increasing prices as we sit here, and it has nothing to do with supply chains. It has to do with their infinite, unrestrained power to raise prices, to raise profits. Where are we?
Congressman, we have some authorities, as you know, to take some action to try to help keep drugs at the prices that are fair, but we need more authorities. That question, where are we, is a question I know we're posing to Congress. Where are we? How close can you come to actually giving us the statutory authority we would need to actually be able to competitively drive down the price of prescription medication? And so we'll do what we can with the authority we have. It certainly would help if Congress passes a measure that enhances our ability to actually go toe-to-toe and negotiate for fair prices for Americans.
Okay, thank you. And my third topic, Mr. Secretary, is on substance abuse. In Vermont, we have this program that's working out, combining telehealth with a system where the medically assisted medication is in a wheel that can only open every 24 hours, and a person can go on their app in their home, and in the visual observation of the provider, who may be 100 miles away, take that pill, and there's assurance that there's no abuse. It's really a tremendous program. We had one person who said it saved her life because she didn't have the ability. She had no car, and she couldn't get to where she had to be. So is there any hope that we could have that sensible approach, which we have on a pilot basis in Vermont, institutionalized?
I think we've learned, as a result of COVID, quite honestly, how much we can institutionalize when it comes to telehealth. But we need, again, statutory authority, because some of the prescriptions are written into law, and we need Congress to act to give us more discretion. Right. But we have certainly learned how important telehealth can be.
Okay, I yield back, and thank you to all the healthcare workers that have been sticking through it for over 2 years. Thank you, Madam Chair.
Sure. Gentleman yields back. Chair is pleased to recognize the gentleman from Florida, Mr. Bilirakis, for 5 minutes to question.
Thank you. Thank you very much, Madam Chair. Welcome, Secretary Becerra. In your budget hearing last year, I asked you a question about partial birth abortion or late-term abortions, which are prohibited under law, in which you stated there is no, and I quote, there is no law that deals specifically with the term partial birth abortion. We know, of course, that this is incorrect. Not only is there a federal law, but the Biden administration and your department in particular has continually undermined these life protections in the years since we've seen you. Mr. Secretary, let's try again. Will you commit to working with Attorney General Garland to enforce the Partial Birth Abortion Ban Act of 2003, which is settled law and upheld by the Supreme Court in Gonzalez versus Carhart in 2007? So will you commit to upholding the law, sir, in this case?
Congressman, thank you for the question. Good to see you. I can absolutely commit to work with Attorney General Garland to make sure we are complying with the law and enforcing the law that we have when it comes to the issue of abortion.
Thank you. Next question, Mr. Secretary. Historically, decisions about the safety and efficacy of drugs have been left to the FDA. Yet in your tenure, HHS seems to have gone the opposite direction by significantly limiting the use of FDA-approved drug that could potentially help millions of Alzheimer's patients in Medicare's national coverage determination, and again through repealing the MCIT, or the Medicare Coverage of Innovation Technology rule, which further limits the FDA-approved products. Why do you seem intent, Mr. Secretary, on adding an additional layer of red tape around your agencies? If that's not the case, please tell me. I think it undermines each other in the eyes of the public, especially with treatments and devices that may help alleviate suffering for patients. And of course, this is a very important issue. I have many seniors in my district, as most do, that have been inflicted with this terrible disease, Alzheimer's. So if you could answer that question, sir, I'd appreciate it very much.
Thanks for the questions. Let me see if I can try to clarify, because it's an important question. There's no doubt that Americans, whether it's because of Alzheimer's or any other illness or condition, are in search of anything that can help their loved ones. I have family that has done the same thing. What we have to remember is that FDA and CMS are two separate agencies with distinct authorities and distinct missions. The FDA is the agency charged with telling us if a particular new drug will be safe and effective. It is CMS's responsibility to tell us if that particular medicine is reasonable and necessary for the diagnosis or treatment of an illness or an injury. Two different entities, two different missions, both based on science and data to give results. And so we cannot confuse what FDA's mission and role is with that of CMS. And that's why you have distinct decision-making. As I've said, the heads of both agencies have come out with a joint statement talking about how it is important, where they're allowed to collaborate and work together so that what we can do is give the American people the best result that we can when it comes to either therapies, drugs, treatments. And I think they're going to work as closely as we can because, as I mentioned, I think to Mr. Upton,
let's make sure that's the case, because there are a lot of people with, again, early onset of Alzheimer's that can be helped with this particular drug. So I'd like to see it approved so that Medicare would cover it for our seniors. Mr. Secretary, this administration continues to pressure big tech to stifle free speech under the guise of health information, despite your own CDC pushing out misleading and inconsistent information. I'm sure from your days as Secretary, of course, State Attorney General of the state of California, you understand the First Amendment prohibits governments from pressuring private company into censoring free speech, which has made recent actions by the Surgeon General particularly troubling, in my opinion. We are in the middle of an opioid and mental health crisis, as you know, with overdose deaths surging to all-time highs, and yet the Surgeon General has instead prioritized policing speech online. Did you direct the Surgeon General to seek information about individuals on social media platforms, and is your aim to silence certain people? If you can answer that question, maybe if you can't right now because we're out of time, I would like for you to submit the answer. Thank you, Mr. Secretary. Thank you. Appreciate it.
You're going to submit on the record, for the record?
We can respond later for the record.
All right, the gentleman yields back. The chair is pleased to recognize the gentleman from California, Mr. Cardenas, for your 5 minutes to question.
Thank you very much, Chairwoman Eshoo and Ranking Member Guthrie, for holding this important hearing and giving us an opportunity to go through the details of the fiscal year 23 budget. Secretary Becerra, it's great to see you. I enjoyed serving with you in Congress, and you served our state well and our country, and thank you for continue dedicating your lifelong service to all the people in this great country as our Secretary. I want to start today by focusing on an area of increasing urgency, the rollout of the 988 mental health crisis line. As you know, 988 will go live in July of this year, just a few short months from now. This program has the potential to revolutionize the way we respond to our neighbors in crisis, and it'll help us shift away from having law enforcement respond to those people with a mental health crisis moment. I truly believe that 988 will save lives, but it will only be successful if we meaningfully fund the program throughout the continuum of care. Secretary Becerra, I'm curious what the administration's vision for 988 is, and my question is this: at its most effective, how does Health and Human Services see 988 operating, and why is the $697 million that was requested for 988 so necessary in order to see that vision become a reality?
Congressman, great to see you. Please tell everyone back home I say hello when you get there. 988 is indispensable. We have to do it right. We have been dispensing some $300 million so far throughout the country to 50 states, the territories, and tribal governments to make sure that we are ready. Remember, we have a patchwork right now of this lifeline for suicide prevention, but it depends on different phone numbers, different entities to provide the services. This is the effort through 988 to combine it all, to put the glue together to make it work for everyone under the rubric of a 3-digit phone number instead of trying to remember a 10-digit number. That's the first part, making sure that someone, if they decide to seek help instead of go the wrong direction, that they get a voice that can support them right away. But you make a really great point, and that is we have to make sure the services follow through. And that's where we want to work with the states, territories, and tribal governments to make sure that's available as well. It's a locally operated system. We're there to help glue it together. We hope that you'll continue to support that.
Yes, thank you so much, Mr. Secretary, for reminding us that 911 is a localized system, but it's a nationwide system. And same thing with 988, it is a localized system. And I want to first thank you so much for the $300+ million rollout that you're already engaged with already to make sure that we can, as best as possible, hit the ground running when 988 goes live in the middle of July of this year. And also, it's about making sure that when people make that phone call, that there's people linguistically and culturally competent to be able to help those people in the most effective way possible. So with that, can you talk a little bit about what effort is underway to ensure that folks, for example, who speak Spanish and other languages can access this 988 line effectively?
Absolutely, and that's a fabulous question because it doesn't help if you make a call and you can't really communicate well with the person who's trying to help you. We're doing everything we can to encourage localities to have the workforce in place that can provide that service directly. We're also helping establish backup centers, so in case a particular location is getting a lot of calls, that there is another backup center that can take up some of that volume. We don't want someone to call when they're making that decision of whether to do something really drastically bad or get some help when they call that 988 number. We want them not to be put on hold and not to get a busy signal. And so first and foremost, making sure there's someone who can actually provide them with real help. And secondly, as you said, making sure we back them up, but all through that process, it has to be culturally and linguistically sensitive so that we're getting someone who can really help that person that's crying out for some support.
Well, thank you so much. And once again, appreciate your proactive efforts. I want to go on to my question about HRSA, the uninsured program. And there are as many as 30 million uninsured Americans who continue to face unique barriers, especially when it comes to COVID-19 testing and care. And unfortunately, that money has run dry. What is the administration doing to address these needs now that this program has run out of money? And what can Congress do to help?
Congressman, we have requested of Congress further support for COVID activities, including that uninsured fund that providers can seek relief from. And we hope that you're able to work through the process and get us some additional resources.
Thank you. I yield back, Madam Chair, and Mr. Secretary, please say hello to Dr. Your better half, Dr. Carolina Reyes. Thank you.
Gentleman yields back. Just a comment on 988. I think members will recall that all of the contracting from HHS to the states went to the state departments of health, not to OES. And I don't know if that was the best design, but that is the design. And I just fingers crossed that it's going to work the way we all want it to, because it's really going to be an essential service in our country. The chair now is pleased to recognize the gentleman from Missouri, Mr. Long, for your 5 minutes to question.
Thank you, Madam Chair, and thank you for being here. Secretary Becerra, when you leave Congress or when you make parole from Congress, do they issue you a hyperbolic chamber?
Congressman, forgive me, you lost me. Can you ask that question?
Well, I've never met any congressman that has made parole around this place, gotten out a year or two later, that doesn't look a lot younger and a lot better than when they left here. And you look really good, so I'm just asking.
I'm taking you home with me.
Hyperbolic chamber when you leave
I'm taking
here.
you wherever I go, Congressman.
Now I'm going to test your history a little bit. Harry Truman, great Missourian, Harry Truman, famously asked to be sent a one-handed economist, as I'm sure you remember, having tired of the dismal, or exponents of a dismal science proclaiming on the one hand and on the other hand. So that's why he wanted a one-handed economist. On the one hand, and I think we need a one-handed CDC director, on the one hand, the CDC feels that the public health emergency is still dire enough to want to extend mask mandates for air travelers and other public transportation, and you're asking for tens of billions of more dollars for emergency pandemic spending. But on the other hand, it's lifting Title 42 May 23rd, if this stay doesn't get waived, as if there's no pandemic at the southern border. Last month alone, there were more than 220,000 migrant encounters at the southern border, and half were turned away by Title 42, which I think is still a necessary and common sense policy to prevent the spread of COVID. Lifting Title 42 sends a clear message for illegal immigrants to come on in, ollie oxen free, and go on to lead to a huge migrant surge that the administration is not prepared for. The estimates are with the Border Patrol, the population of Springfield, Missouri is 169,176 folks, according to the 2020 census. If this Title 42 is lifted, every 9.4 days you could repopulate my hometown, the city of Springfield, Missouri, with 169,176 people. As HHS Secretary, you oversee the CDC. How can you square up the message that the pandemic is essentially over at the border by lifting Title 42, but still bad enough to mandate mask usage for Americans traveling on planes? Are we in a public health emergency or not?
Congressman, thank you for the question. I know a lot of folks are asking the very question you asked. The public health emergency declaration that I issue is based on the data we have about where we are in terms of this pandemic. Title 42 is a separate measure in the statutes that deals more specifically with things like quarantine. It is not the same to equate Title 42 with the public health emergency. Because, as you and I would probably agree, there's still, 300 or so Americans dying every day of COVID. There are still more than 1,000 people being hospitalized every day because of COVID. So we're still in a condition of pandemic, much better circumstance than we previously had found ourselves. But the situation at the border has presented a number of migration challenges. It is inappropriate to use a public health law, Title 42, that deals principally with quarantines, to try to deal with a migration challenge that we face, because CDC is required to look at the facts and the evidence based on health conditions, not on immigration or migration challenges that we face.
We're even now because you lost me on that one. So
I apologize.
It was issued due to a health pandemic, correct?
Title 42 was based on the conditions, the health conditions that we were in at the time that have since changed, yes.
Okay. This issue should not be siloed. Encounters are up 33% since February, and I think that lifting 42 directly affects what happens at the southern border. Its lifting sends a clear signal to me that illegal immigrants won't be turned away, and we're seeing a massive surge at the border because of it, and I find it very concerning. If the Biden administration not taking it, is the Biden administration not taking into account when looking over our overwhelmed border?
Congressman, remember that President Biden presented his first week in office a plan to reform a broken immigration system. And what you're pointing to, I think, again, verifies that we have a broken immigration system. We should be using immigration laws to deal with that border immigration challenge, not healthcare laws to try to deal with it. It's like using a knife to do work that you would use a screwdriver to do. You might have some success in some ways, but it's not the right tool.
Okay, thank you. I appreciate you being here. I yield back.
Thank you.
Gentleman yields back. The chair is now pleased to recognize the gentleman from Oregon, Mr. Schrader, for your 5 minutes to question.
Thank you very much, Madam Chair, and I thank the Secretary for being here. Always good to see a former colleague and who's moved up the food chain and is doing such great work, frankly. Well, I'd like to talk a little bit about healthcare. I'm very pleased to see that the President's budget includes policy that I've sort of worked on for the past few years to end some of the gaming of the generic drug application process and bring less costly, effective medications to the market sooner. If anything, my understanding is that the proposal goes a step further in the President's budget and uses commercial marketing rather than just filing as a time trigger. The blocking act that I've proposed has a slightly different mechanism. What concerns does the administration have right now around generic drug applications, filing and marketing and all the timelines?
Congressman, I think the President would likely tell you that we want to make sure that generic drugs, safe and effective generic drugs, are made available as quickly as possible to the American people. We know that within that sphere of the manufacturing industry for drugs, lots goes on. I can tell you about this as the former Attorney General in California, how we try to make this a more competitive marketplace and how we try to stop the gaming of deals that are done behind closed doors that limit accessibility to safe and effective generic drugs. The President has charged us to do everything possible to try to make the drug industry a more competitive place. That would mean that we'd be able to put generic drugs out into the public's hands more quickly.
Totally agree, totally agree. We've also been working on a Biosim Act to encourage providers to use more of the biosimilars like they do in Europe and reduce drug costs. So we're totally in sync, I think. Switching gears to mental health, youth mental health in particular, how are the increases in critical SAMHSA programs proposed in the President's budget going to help address the mental health needs of our kids out there?
Congressman, hopefully working with you and folks in your communities, what we'll do is we'll concentrate some of those resources that I hope you're able to get to us to help children, whether in school, through community settings, so they can access that mental health coverage or service a lot faster. We find that still too many families don't have good mental health coverage in their health insurance plans. We're trying to change that as well to make sure that no one is denied health care simply because it's a mental health condition versus a more generalized physical health condition. But we'll work with you because if we get the resources that the President has asked for, game-changing level of resources, we should be able to go into your communities and communities throughout this country and really make a difference in the lives of so many young people.
Well, I hear so much, certainly post-pandemic and even a little pre-pandemic about, some of the travails of young America, dealing with lack of social interaction in the traditional school environment. Some of the problems that are at home became exacerbated as a result of the COVID epidemic and, the lack of counselors and whatever that are out there for these children to seek. Like we had when I was a youngster, we actually had counselors in the schools, every school. It's been very different. Kind of leads me into the last question on provider workforce. Just got off a call a few moments ago with our hospital association. I've talked with our nursing providers. I mean, it's in turmoil. The lack of workforce is legendary now post-COVID. Well, not quite post-COVID yet. We're still in COVID. I totally agree with that.
That's right.
What is HHS doing to evaluate current flexibilities and programs during the COVID-19 pandemic and help get healthcare workers, CNAs, whatever, to the workforce quicker and on a more permanent basis?
Congressman, you hit it right on the nail. We're losing nurses. We're having facilities fight for health professionals, and they're paying major dollars to have these traveling health professionals come to their facilities. It's a difficult situation. We just recently a couple months ago, put out a grant proposal of about $103 million to help with facilities that are trying to help their workforce cope. So whether it is facing burnout, whether it is those who are trying to get trained up so they can move up a notch, or whether it's simply giving that workforce a little bit more time to rest, that money we've made available so that providers could actually reward their workforce for everything they've done during COVID. And it's not enough, obviously, but it's something to try to help deal with the burnout that we're seeing in the industry.
Very good, very good. Look forward to working with you. Thank you very much.
Absolutely. Thank you.
I yield back, Madam Chair.
Gentleman yields back. Chair is pleased to recognize the gentleman from Indiana, one of our doctors on our subcommittee, Dr. Bouchon.
Secretary Becerra, thank you for being here today. Appreciate it. I want to start today talking about a topic that you and Congress have corresponded frequently on since you were confirmed, and that's the No Surprises Act, or the surprise billing legislation. As you know, the U.S. District Court for the Eastern District of Texas recently ruled that the rebuttable presumption of a benchmark rate in the interim dispute resolution process portion of your rule was not valid. The judge ruled that this provision conflicts, quote, conflicts with the unambiguous terms of the act. I and the majority of my colleagues on both sides of the aisle involved in writing the legislation have sent multiple letters to you and have been speaking frequently with your office, both before and after the issuance of the rule, stating that this provision, in our opinion, violated congressional intent and the delicate balance we struck in getting a deal that protects patients and is fair to both providers and plans. So, on behalf of the administration, can you commit to more closely following the will of Congress and also the courts and finalize a rule that does not include a rebuttable presumption of a benchmark in the independent dispute resolution process?
Congressman, thank you for the question. We are in the midst of trying to issue the final rule. We are heeding the ruling, the court ruling that came out recently. We are going to try to stay in communication with those of you who work very hard on this legislation. There is no doubt that the American people want to see this work well. They should not be blindsided with these medical bills that we're not expecting. And so we're going to do everything we can to continue to extract the patient from that food fight that occurs between the provider and the insurer. And working with you, we hope we're able to issue fairly soon a final rule that puts into effect in a meaningful way that new law.
Great, thank you, because and to your point, we all agree that the patient has to be taken out of this. And we heard testimony of just some crazy cases where people got these tens of thousands of dollars in bills, and we just can't have that. And we're in agreement. I look forward to working together with you. As you know, the rollout of the federal portal for the payment disputes, was delayed by nearly a month and a half. So that has continued. It's my understanding that due to the delay, there are now hundreds of payment disputes where the 30-day business day open negotiation period has already expired, and that was in the law. And there are many more disputes where the 30-day business days will be exhausted soon. This means that there is going to be a flood of disputes that will inundate the federal portal as well as the federal arbiters over the next couple of weeks. I have two questions about that. What caused the delay, and will the federal portal be able to handle and resolve the flood of disputes that were created by the delay?
Yeah, and Congressman, I think lawsuits have consequences, and when we have to wait for a ruling to determine how we can move forward, it makes it difficult. We intend to move as quickly as we can because we want folks to believe that this is a law that they can count on. So we look forward to working with you. The sooner we get that final rule issue, I think the easier it will be to try to process these cases.
Great, thank you very much. On another topic, the Medicare Access and Chip Reauthorization Act, or MACRA, and the topic of congressional intent. I mean, you were in Congress and on the Committee of Jurisdiction when we worked to pass MACRA, so I know you can appreciate me wanting to make sure the agencies are continuing to use their authority to help maximize what Congress intended to do. I still hear concerns about how physicians find it hard to enter into and participate in alternative payment models, or that the incentive just isn't there to do so. I think we need to have more oversight hearings on MACRA, something I've called on this committee to do, so that we can see why this is the case, and in general, look at how we can build upon what is successful about MACRA in shifting to a value-based healthcare system, and not just have a fee-for-service, based it on value and alternative payment models. Congress and HHS must find solutions to the existing physician shortage, and making sure we better value providers' work is a great first step. As you know, adjusted for inflation, in-practice costs physicians pay within Medicare actually declined 20% from 2001 to 2021. Given that the cost of running a medical practice has increased 39% over the same time. Otherwise, reimbursement declined 20%, increase in practice costs up 39%. I know I'm out of time, so I'll submit this for the record, but I'm going to read the question. What is HHS doing to stop the decline in physician reimbursement in Medicare? And we will submit that for the record. Thank you. I yield back.
Gentleman yields back. Chair is pleased to recognize another one of the doctors on our subcommittee, Mr. Ruiz, for his 5 minutes to question.
Thank you, Secretary Becerra. It is good to see you, my friend. Thank you for being here today. I know that the administration as a whole and you personally hold health equity as a top priority. I appreciate all the work that you have done on this front, and I look forward to continuing to work together on policies that address this critical issue. As someone who grew up in Coachella and then later practiced medicine there in the Coachella Valley in the district I represent, I saw firsthand the very real effects that health access disparities like physician shortages have on the health of underserved populations. I came to Congress to fight for health equity and to level the playing field so that people have the same access to affordable health care regardless of where they live or how much money they make. A shortage of healthcare providers is one of the biggest challenges to healthcare access that we face, and the outlook is not good. According to research by the Association of American Medical Colleges, by 2034, we will have a shortage of up to 124,000 physicians. That shortage is most pronounced in underserved areas, and that is why we need to make sure that we are increasing provider access in the areas that need it most. I recently met with regional leaders from Eastern Coachella Valley and Imperial County, two of the most underserved areas of California, to discuss healthcare challenges that our areas face. And we must ensure that these areas do not get left behind. That is why I've been a longtime advocate of the Teaching Health Center program, which gets more providers in underserved areas. Not only are physicians who train in community health centers more likely to practice in underserved areas, it also generates a more diverse workforce in underserved areas. Because of the program's success, Congress has allocated increased funding over the years to expand the program. However, one of the biggest challenges that the program has faced is uncertainty over funding, which relies on short-term reauthorization from Congress. That makes planning difficult, which in turn makes it harder to expand and recruit residents. Given the workforce shortages that we are facing across this country, we need to robustly support this program. And this committee has shown bipartisan support throughout the years on this issue. I have worked with Ranking Member McMorris Rodgers over several years to lead legislation on this issue, and I was thrilled when Chairman Pallone introduced legislation last year to permanently fund and expand the program. Secretary Becerra, do you support Teaching Health Center program parity with Medicare GME, which is permanently authorized and funded, as well as expansion of the program beyond what was authorized in the American Rescue Plan?
Congressman, first, great to see you, and thank you for all your work. But on this issue of community health centers and allowing them to be the teaching centers as well, you had me at hello. It is indispensable to allow these health centers, quality health centers that are providing care to some of the least able to afford it, with the capacity to build, and providing them with the workforce, the next generation of doctors through the GME funding, but doing it specifically for these community health centers is not only a smart thing to do, but it's the right thing to do. So absolutely, we look forward to working with you and others, and you'll see in the president's budget, we make a commitment both in the mandatory allocation and in the discretionary allocation to continue to grow the workforce through these community health centers.
Thank you. I fell in love with patient care at a community health center when I was a freshman pre-med student in undergrad. Now, I'm going to change gears a little. Here, I wanted to ask about an issue that I am hearing about regarding workforce issues at CMS call centers. Specifically, that workers at 2 of the call centers that operate CMS's customer service lines went on strike last month. We cannot be in a situation where these crucial services for seniors are disrupted. Can you commit that CMS will work with me in good faith to ensure that there are not work stoppages that will lead to service disruptions?
Congressman, we commit to work with you to try to address some of these issues.
Thank you. It's very important for the seniors in my district. It's very important to the workers that provide good services, and we want to make sure that they have a fair shot and that our seniors get the best service that they can possibly get. And so I appreciate your time. I appreciate the work that you have done, especially during the pandemic. We've seen access to vaccine disparities dissolve within Hispanic communities thanks to your excellent work, and I commend you and the administration on the work that you're doing on health equity. Thank you. I yield back.
Gentleman's time has expired. Chair is pleased to recognize the gentleman from Florida, Dr. Dunn, for your 5 minutes to question.
Thank you very much, Madam Chair, and Ranking Member Guthrie for holding this hearing today. And thank you, Mr. Secretary, for being here. I do have serious concerns about the President's 23 fiscal year budget, which calls for more spending on radical progressive priorities that are frankly out of touch with what America really is interested in at this time. Unfortunately, many of the issues we faced a year ago are even worse today. Public confidence in our federal health agencies is at an all-time low, and that's due to confused messaging by both the CDC and the President's COVID response team. Politics and policies that are encouraging school closures and unnecessary student maskings failed our children, set them back tremendously. This failure is evidenced by CDC's own decision to lower the expected developmental milestones for children earlier this year. And that outraged pediatricians, speech pathologists, and parents. This is nothing new. I think, the administration often changes COVID rules on a whim to serve capricious political goals and interests. Mr. Secretary, I want to suggest to you a commitment to transparency just to get our public health agencies back on track. CDC needs to be more forthcoming about their data and who influenced that and who continues to influence their issued guidance. NIH, we have found, has actively suppressed information regarding the genetic sequence of SARS-CoV-2 and the circumstances of the research conducted in Wuhan, China, with NIH dollars. American people deserve answers about the origin of COVID. So I'll sincerely hope that you look into the issue internally, ways to improve the public's confidence in federal health agencies. So question, recently more than 60 immunology experts and executives wrote to the FDA to express concerns over the failure to incorporate cellular immunity into the vaccine studies. I too am worried about that oversight. Congress actually included language in the fiscal year 22 appropriations bill encouraging NIH to utilize cellular immunity data in research on vaccines and requested an HHS-wide assessment of your efforts to incorporate that data. To underscore that cellular immunity is an extremely important component of the immune response, and it's been well recognized for a number of years as the key mediator of long-term immunity in coronaviruses. Predates the pandemic. So right now, the Biden administration is talking about rolling out another round of booster shots for adults and booster shots for kids 5 to 11. But yesterday, the CDC announced that 3 out of 4 children have already had COVID. So why aren't we looking at T-cell immune response data to make vaccine decisions?
Congressman, I think I followed most of where you were going with your question. What I can tell you is that The CDC has continued to try to be as transparent as it can with the information that it has. And the NIH, in coming up with its decisions on how to do its research, is also try to be as transparent as it can.
I'm gonna have to reclaim my time just because it's short. Everybody has told you that, unfortunately. But I will say respectfully, I have not heard yet back my requests for information from the fiscal year 22 budget hearing. So that's a year ago. We would really like to, you heard that from other members as well. They would like to hear back from your department when we submit written questions. And NIH and CDC are notoriously poor about that, just for your information, as a guy on the other side. So I'm a grandfather. I'm really concerned about the consequences of lockdown on kids. And you're probably aware that Governor Ron DeSantis had made in-person learning a priority. I encourage you to review data from the state of Florida and other states that kept the school doors open to explore the advantages of that for our children. I have another question regarding the status of therapeutics funding, research funding at BARDA. I know we're short on time. You will get this question in writing, but the truth is we only pursued monoclonal antibodies. We did not pursue the small molecules that we know are so effectively active against a lot of these pathways. We have really good science on this, and I think that HHS, certainly NIH, CDC, and FDA should be keenly interested in following this data because it is outstanding. So you'll get those questions in writing from me. Please, let's hear back this time. Thank you very much, Mr. Secretary. Madam Chair, I yield back.
Gentleman yields back. I just want to make a quick comment because there's a consistency, I think, in terms of a theme today at our hearing about the loss of confidence in public health during the pandemic. I, for one, could not help but notice over a 2-year period where the chipping away in terms of attacks on some of the most revered people in public health coming out of the Congress. Dr. Fauci being that person. I mean, here is the man that led the effort to cure HIV and AIDS. What are we doing to ourselves when we do that? So we all want confidence, to the American people to have confidence in their institutions. But this institution, I think, can be found guilty on many fronts of diminishing those institutions. It damages our democracy. The chair is now pleased to recognize the gentlewoman from New Hampshire, Ms. Custer, for her 5 minutes to question.
Thank you so much, Chairwoman Eshoo, and I want to welcome our good friend and former colleague, Secretary Becerra. I'd like to acknowledge at the outset my appreciation for steps that the Biden administration is taking to tackle the addiction and mental health crisis in this country and the investments in this budget in adolescent mental health especially. As we look to the needs of Granite Staters and communities across the country after COVID-19, we must build on the work of this committee and ensure that Americans struggling with mental health and addiction are supported through increased access to treatment and recovery. And I want to thank you for that. Secretary Becerra, another constant concern I hear from my constituents in New Hampshire is the rising cost of prescription drugs. I myself was surprised to pick up a medication the other day and my copay was $182. Drug costs in the United States are an average 3 to 4 times higher than in other countries with comparable economies. But in contrast with many other countries, and I might point out in contrast with the Veterans Administration and other payers within the United States, the Medicare program lacks the ability to negotiate with drug manufacturers on a volume discount to lower the price of drugs. Do you agree that allowing the Secretary to negotiate to lower the price of certain medication in the Medicare program is critical to lowering overall drug costs? And is it fair to say that there are no other as effective tools to constrain drugs costs when a drug lacks competition?
Congresswoman, first, good to see you, but secondly, easy answer, yes, absolutely agree.
So we've heard from opponents to these reforms who claim that provisions like drug price negotiation will harm innovation and delay the discovery of new cures. Do you agree that it must be one or the other, lower costs or new cures? Or instead, can we protect patients while we also protect innovation?
Congresswoman, we're a society that relies on competition and the free market. It makes no sense to not be allowed to negotiate for the best price. You wouldn't accept going into a car dealership and having to take sticker price for that vehicle. You wouldn't expect to just take any price from some mechanic if you have to get that vehicle repaired. It's a true and tried provision, part of our life in America to be able to get the best price we can and negotiate for that best price.
Well, the president's budget reiterates your support and the administration's support for a comprehensive prescription drug pricing plan. How did the drug pricing reforms included in our Build Back Better Act passed by the House fulfill the administration's goal of lowering costs for consumers and patients?
Congresswoman, one, that provision would have allowed Americans to have a better insight into how drug manufacturers price their products. That transparency that the bill would have provided is wholly overdue. As they say, sunshine is the best disinfectant. We should get to see the types of prices that we would be charged. Secondly, by being able to actually negotiate on behalf of Medicare's 65 million or so beneficiaries to get the best price for all of them. That leverage allows us to get good prices, not just for those seniors and those under Medicare, but it would then set a trend for other pricing done in the private sector through the other private markets, whether it's through Medicare, Medicaid, the Veterans Administration, or through health insurers. The more transparency you have, the more the right price will be negotiated because people get to see what's really at stake. And so to hide that ball from the American public keeps prices very high.
And do you agree that these policies, the transparency combined with negotiating a volume discount for the medication, work in tandem to effectively lower drug costs and stop price increases?
Absolutely. And at the same time, I believe it helps promote innovation because we all get to see where we need medicines, and manufacturers will go into that space to provide the medicines where the demand is there.
Terrific. Well, thank you, Secretary Becerra. I'm so pleased the administration is committed to lowering prescription drug costs for my constituents, for Americans across this country. We have the solutions to lower drug costs. We pass them in the House, and I look forward to seeing those enacted into law, and I yield back.
Gentlewoman yields back. Chair is pleased to recognize the gentleman from Utah, Mr. Curtis, for your 5 minutes to question.
Thank you, Madam Chair. Thank you, Mr. Ranking Member, Mr. Secretary. You may not remember, but last year in this opportunity, I invited you out to Utah, and I'm going to re-extend that invitation. And
let's work out a date, Congressman.
We would very much enjoy that. I know as well as anybody how busy you are and how busy the schedule is, but you also know the sense that in Middle America that we have for wanting to be part of the solution, part of the answers. I think what we're doing in Utah, a lot of things very well, and would also love to brainstorm with you what we could do better. So,
done deal. We'll make it happen.
Excellent. I like that. Maybe the best question of the hearing, right? As we know, the president's budget is a reflection of priorities. And so I want to talk to you about one of the priorities that's showing up in the budget that concerns me. Not because of what's on face value, and let me explain what I mean by that, but your budget allocates funding. It went from $10 million to $110 million for studying the potential impacts of climate. And for context, the budget has $97 million for nutrition research. And I'm the first here to say what's happening with the climate is important. We need to pay attention to it. It has impacts. But can you see how that potentially, Madam Chair, I think we've got somebody.
Sounds
like
There's I think Annie Custer, you need to shut your microphone off. I think I recognize your voice. You're interfering, and I think you don't mean to. Okay,
Sounds like she's got it.
all right, got it?
All right.
Coast is clear.
Thank you. And let me just emphasize, on this whole thing, I founded the Conservative Climate Caucus. I'm very aware of the importance of this. But 70% of Americans are overweight, and prioritizing climate over right nutrition and diabetes and healthcare. You can kind of see the optics of this, and I would love just to hear from you about the prioritization of this and realizing, that every dollar people are hoping are spent is on their issues, and have we perhaps made a mistake by prioritizing climate in this budget?
Congressman, first, can I thank you for the thoughtful way you posed the question. I hope I can convince you on that trip to Utah that the investment we're making to deal with climate change is going to be critical to make sure Americans stay healthy. You come from a state like me, California, where the warm temperatures, the high heat can oftentimes have major impacts. We are finding that there are communities in California that are running out of potable water. You cannot raise a family if you can't access potable water easily, and you can't afford to pay constantly for bottled water. And so there are many ways that the climate changes that we're seeing are affecting families. We want to make sure we're doing everything we can. We're going to put it in perspective because the kind of investment we're putting into that office, as opposed to, as you mentioned, food, nutrition, obesity, it doesn't compare. We have absolutely been engaged on nutrition, issues of obesity for a long time. We're very committed. It's not doing one over the other, but it is recognizing that climate change has become a major issue when it comes to the health of our country.
Your answer doesn't surprise me. Let me just reemphasize from my district's perspective, the optics, right, of this, and of saying, look, of all the things that are out there, they're important. And when you come to my district, you'll hear this. There's a fear that climate will be declared a public health emergency. Could you comment on that? And I can tell from your look, you're not sure of my question.
Right, you can't pose the question again.
Is yes or no, do you intend to declare the climate a public health emergency?
Well, I think most people recognize that climate change has already become an emergency.
Right, but you understand the official declaration, right, that I'm...
As you know, there are many elements that go into any kind of declaration of a public health emergency.
So to be clear, is that something that we'll see coming?
Well, when it comes to the public health emergency, we will outline the different criteria that we take a look at. For example, right now we are in this pandemic and we are in a state of a public health emergency. It relies on the evidence, the science to guide us on that, and we would do the same thing anytime we're ready to declare any form of public health emergency.
I just have a few seconds left, and I want to
No,
make...
you have another 20 seconds.
Okay, thanks.
I'll add on.
Thanks, Madam Chair. We know that COVID-19 exacerbated existing healthcare problems. Many in Utah, across the United States, are experiencing isolation. Children's mental health, I think we could agree, is in a crisis. The more time that goes on, the more data comes out, about some of the decisions that we've made. I think specifically in my district, you're going to see a exploding of drug and substance abuse. We actually took a few minutes the other day and sent out a notice to my district and said, hey, I'm going to have a chance to speak on this. And these are the responses that came in, personal stories about problems with substance abuse. 250 Americans every day die to drug overdose. Really want to emphasize that, really realizing the amount of time when you come to Utah. I would love to talk to you about that as well. Thanks, Madam Chair. I yield my time.
Gentleman yields back. That's going to be quite a visit. Exactly. The chair is pleased to recognize the gentlewoman from Illinois, Ms. Kelly, for your 5 minutes to question.
Good afternoon, Secretary Becerra. Good to see you so soon again. Thanks for being here today. Just a few weeks ago, as you know, we observed Black Maternal Health Week, and we just discussed it last night, the issues around maternal mortality rates, and especially when it comes to Black mothers who are 3 to 4 times more likely to die from a pregnancy-related death than white women. And I was very, very proud that the American Rescue Plan included a policy that I pushed for with strong support from this committee that would give states the option to cover new mothers on Medicaid for 12 months postpartum. Mr. Secretary, how many states have adopted the option to provide 12 months of continuous coverage postpartum in Medicaid? And very proud that Illinois was the first.
Congresswoman, first, thank you for what you did there, working with your colleagues. Crucial. We had 5 states, as you mentioned, Illinois being the first, to come on board to take us up on the challenge to increase access to postpartum care for women for up to 12 months instead of just 60 days. We are now talking with another 11 states, 12 states who have indicated a deep interest in moving in this direction as well. And so as a result of the American Rescue Plan, we hope that what we can do is get some close to 800,000 women in America under full coverage for a year of postpartum care rather than just have it drop off after 60 days.
That's great news. Can you just talk about some of the benefits of providing 12 months of continuous eligibility postpartum in Medicaid and how it will help address the maternal health crisis?
Congressman, I say this not just as secretary, but as the spouse of a obstetrician gynecologist who can tell you about many, many experiences with some of her patients. 60 days is helpful, but you don't stop being a mother with all the stresses. The child doesn't all of a sudden get healthy after 60 days. There's a lot that happens after 60 days. We want to continue that care so that child grows up healthy and strong. We want that mother to be healthy physically and mentally, going through that process of becoming a parent. And it's important that we continue to provide access to the different health services that whether mother or child will be needing over that course of time, because you want to set them on the right track. And so this coverage that you made possible is indispensable.
Thank you. I am thrilled that so many states have decided to take this option, but unfortunately, we know this policy will sunset in 5 years. And what's worse, we're not saying 50 states. So some states have decided not to implement this policy at all, leaving mothers without coverage at a very vulnerable time. We need to pass a mandatory and permanent Medicaid postpartum extension policy that's in my Mama's Act, and that was included also in Build Back Better. But also I wanted to talk about how we're closing the Medicaid coverage gap, help women who are seeking prenatal care or care early in their pregnancy.
We hope that more states will take up the opportunity to expand Medicaid coverage. We hope that Congress succeeds to provide several million Americans who are not in states where the expanded Medicaid has been available. And what we know is the results are that families get upfront preventative care early, and it helps American taxpayers from having to spend more money, whether it's in an ER visit or whether it's because conditions get so difficult. And so whether it's through Congress, and I hope that you all are able to have success in expanding access to coverage in Medicaid, or whether it's simply the fact that the 12 states that have still not expanded Medicaid coverage to their citizens will take that on, that one way or the other will continue to see more Americans have access to quality health care.
Thank you so much. With the leaders of the Tri-Caucus, the Democratic leadership and the president, we sent a letter to outline the key Medicaid policies that should be included in the final reconciliation bill. Thank you so much for all the work you do. It's great to see you, and I yield back.
Thank you. Gentlewoman yields back. Thank you for your extraordinary leadership. This is what is being heralded, came from the Congress. And we have an agency that's implementing well. But really, I think were it not for Congresswoman Kelly and the work done of the subcommittee and the support of the subcommittee going to the full committee, we wouldn't be hailing what we're hailing today. These are such important, it's such important progress for our country. Chair is now pleased to recognize the gentleman from Pennsylvania. Another one of the doctors on our subcommittee, Dr. Joyce.
Thank you, Madam
5 minutes to
Chair.
question.
Mr. Secretary, I'd like to ask about healthcare access. Since your department says that that's a priority in the recent RFI on access to care and coverage in Medicaid and CHIP. In that RFI, CMS asked for feedback on ensuring access to timely providers and services. So I would like to know, do you think it would be in the interest of Medicaid beneficiaries if a state were to restrict access to providers of mandatory services so that only hospital in their county or service area in their region would be able to provide Medicaid services?
Dr. Joyce, I want to make sure I understand the question. You're talking about a program where Medicaid would compel the restricted access of services?
Compelled only to be with hospitals that had eligibility requirements by whether or not their hospitals were unionized.
So if there is a requirement that's based on a level of care, or if there are criteria that are imposed before a hospital or other provider can make use of Medicaid services, it may be as a result of an effort to make sure that the care that will be provided is of quality. I'd have to have more information to answer your question more directly, but certainly Medicaid is in the game of trying to increase access, not decrease access to care.
And if access was decreased because in rural areas or throughout the Commonwealth of Pennsylvania, hospitals are not unionized and thus would not be able to accept Medicaid patients and would then sever the services that are available for those Medicaid patients, would that be unacceptable?
We certainly want to make sure that Medicaid is supporting hospitals or providers that offer quality care. And we want to make sure that we keep Americans and patients away from facilities, providers that don't offer that level of care that we would expect, because not only would it be bad for the patient, but it would be bad for taxpayers to be providing care in that way. So again, knowing the particulars would be helpful to be able to give any specific response to any particular provider.
So earlier you stated that you're committed that Americans stay healthy. I share that commitment. Americans who rely on Medicaid for health care need to have access to care. As you know, per the letter that I sent 2 weeks ago, my home state of Pennsylvania is preparing to prohibit MCOs from contracting with hospitals and other providers that had a work stoppage in the past 5 years if the provider doesn't have a collective bargaining agreement or labor peace agreement in place. This provision would not only be inconsistent with your recently published RFI, but it would also appear to be in violation of existing Medicaid statutes, including 42 CRF 438.206, availability of services, 42 CFR 48214, provider selection, 42 CFR 438.12, provider discrimination prohibited, and a large amount of regulations and guidance that flow from these laws, notably time and distance standards, network adequacy in particular, as well as a state guide to CMS criteria for Medicaid management career contract that your agency just released in January of this year. With that information, I would ask you, Mr. Secretary, would you be prepared to reject a contract amendment, or a state plan amendment that undermines access to care by denying Medicaid beneficiaries the access to only hospitals in their county or in their service area?
Congressman, let me commit to you that we certainly are willing to work with you if you believe that there is a state plan for your state of Pennsylvania that is not working in the best interest of any Medicaid patients. Certainly we will take a close look at that. We're in the process of reviewing any number of requests from different states on how they implement their Medicaid program. We always, as I said, try to make sure that we move towards increasing access to care, quality care for those patients who would receive it through Medicaid.
Thank you, Mr. Secretary. I look forward to working with you on that issue. It is important and it is beneficial that Medicaid patients have access to more facilities regardless of the presence of qualifying relationships with organized labor. Thank you for agreeing to address that with us.
Gentleman yields back. Chair now recognizes the gentlewoman from California, Ms. Barragan, for your 5 minutes of questions.
Thank you, Madam Chair. Thank you, Mr. Secretary, for being here today and for all your work to make sure that there is a strong vaccination campaign to get the vaccine across the country and to people who are most vulnerable, and that we're continuing to fight COVID as we see new variants come through. I heard you testify about the difference between the FDA and CMS, and I just want to comment on the decision that I disagree with CMS on finalizing a coverage policy to tighten and restrict coverage of FDA-approved Alzheimer's treatments for an entire class of drugs. I had a chance to speak to the administrator, and I had a chance to hear your response. There seems to be a disconnect. We're saying that the FDA can say something is safe, but then the CMS will decide whether it's reasonably necessary. That to me seems like we're saying the FDA can't judge clinical data, but CMS can. It's also telling me and sending me a message, and this is about access. Once the FDA passes it, people who have money and can pay for it will get it. People who are under a CMS program won't. And that to me is an access issue that continues to trouble me and something that I continue to have an issue about. We talk about access to health care. This is access to health care. The decision should be between a patient and their doctor. And so I will continue to speak out because I am just so disappointed. And that this is the first time we have had a drug that has been approved under the accelerated approval process that hasn't been covered by CMS, a drug. So that's the comment I have. I'm going to move on to my questions. And those are on different topics. The first one is on the Children's Health Insurance Program. Secretary Becerra, the Children's Health Insurance Program, or CHIP, has been a remarkable success, reducing the uninsured rate for children by 68%. In 2021, CHIP enrollment averaged over 7 million individuals per month, making it an essential source of children's health coverage. And during the pandemic, CHIP helped to ensure that children and pregnant women had free access to COVID-19 testing and treatment. Despite its success, CHIP is the only federal insurance program that isn't permanently funded. So every few years, Congress scrambles to prevent CHIP from running out of money. Can you speak to the importance of CHIP and your thoughts on having it permanently funded?
Congresswoman, first, thank you for all the work that you've done on these issues. There would be many more children living in poverty if we didn't have the CHIP program. There would be many more children who we would discover later in their life that they were suffering from illnesses that might be life-threatening, but are able to get the care they need to prevent that from ever taking a life with the CHIP program. And it just, as I said earlier, my mom would always tell me, mejor prevenir que remediar, better to prevent than to remediate. CHIP is a program that lets families who are lower income prevent illness in their children from becoming life-threatening. And we would be in disastrous shape if we did not reauthorize CHIP.
Thank you. I want to talk a little bit about the cancer moonshot and multiple myeloma. Mr. Secretary, an important factor in reducing the mortality of cancer is research and early detection of rare and aggressive forms of this disease. For example, multiple myeloma is a rare, fatal cancer of blood plasma cells with racial disparities in all ages, all stages of the disease. African Americans account for 20% of patients diagnosed with multiple myeloma, despite being only 12% of the US population. My own sister, who's only a year older than me, was diagnosed and is now battling this, and will have it for the rest of her life. There is no cure. Barriers to treatment are also present. Latinos have the lowest stem cell transplant rate for the treatment of multiple myeloma. Given the mortality associated with rare cancers and lack of treatment options, could you discuss how the reignited Cancer Moonshot would expedite research to improve the lives of people with rare aggressive diseases such as multiple myeloma?
Excellent question. And one of the things that we are doing to try to help launch the President's Moonshot proposal is to start by getting people back into the doctor's offices to get screened. There are estimates that 9 to 10 million Americans fail to make their screening appointments for cancer because of the pandemic. We are going to launch an effort to try to encourage Americans to go back and get checked, because the sooner you get checked, the quicker you can address some of those cancers that can't be preventable. I will tell you that we're also making every effort to make sure that we take equity into account in who participates in these clinical trials and the work that is done to make sure that we have treatments for everyone.
Thank you, Mr. Secretary. Madam Chair, I yield back.
Gentlewoman yields back. The chair is pleased to recognize the gentleman from Texas, Mr. Crenshaw, for your 5 minutes to question.
Thank you, Madam Chair. Thank you and the ranking member for holding this important hearing. Thank you, Mr. Secretary, for joining us in person. I got to say, it seems like there's some bipartisan agreement on how CMS does approvals, so that's good to hear as well. It's not what I want to talk about, though. I want to talk about Title 42, as you can imagine. And Mr. Becerra, I want to ask you, why do you want to end the expulsions at the border currently authorized under Title 42? I want to understand this.
Congressman Crenshaw, let me try to explain. We don't base determinations about Title 42, which is a healthcare law that deals principally with quarantining activities. We don't base those on what is occurring in terms of the border on immigration. It is a healthcare measure, Title 42, that is rarely applied, and when it is applied is because the health conditions are such that CDC has recommended that we use it to try to keep populations from intermingling in ways that could lead to worse results when something like COVID-19 hits us.
Right, and I would take that as the answer if you didn't also support Title 42 authority to continue the mask mandate on airplanes, to mask children in Head Start programs, to authorize the eviction moratoriums. So you got to be consistent. You either believe that Title 42 is still a necessary thing to do because of COVID, or you don't. So which is it?
Well, in the various instances that you've raised, you'll see that the guidance that CDC has provided has changed, whether it's for cruise ships, whether it is for children in school settings. They've all been adapting to what the facts and the medicine and the science tells us should be the case with regard to those.
I find it hard to believe that the science tells us that there's still COVID on airplanes, even though that's been debunked wildly. I mean, many times, given the filtration systems on airplanes. They're still pushing for that mandate, but there's no COVID on the border with 8,000 people crossing every single day. And with Title 42 rescinded, all estimates, this isn't even a partisan estimate, all estimates point to about 18,000 a day. So again, which is it? Is COVID still a problem or is it not?
Congressman, maybe you disagree, but we are losing more than 300 Americans a day. We still have over 1,000 Americans being hospitalized every day.
So it is a problem. So then why not keep Title 42 at the border? Why not allow those expulsions?
Because as I explained, the law that I use to declare a public health emergency is different from the law, Title 42, that you're referencing, that has used principally and only very infrequently to deal with things like quarantines.
Right.
We have seen an evolution of the pandemic.
I don't know, but again, there's clearly no consistency here, and that's the problem.
There is absolutely consistency in what CDC has done. The CDC has been using the facts and the science to drive what it does. Cruise ships are different from schools, which are different from the border. And it's not a cookie-cutter approach to the use of our healthcare authorities. Title 42 is not the same as the emergency declaration.
I think we've utterly failed to provide the scientific data and scientific backing for saying that COVID measures are still required for children over 2 years old and on airplanes, when both of those things have been debunked many times, versus the border with 18,000 people potentially crossing every day. And by the way, filling up our hospitals, filling up on buses, moving into the United States, getting tickets to wherever they want. This is a problem. And also to say that HHS doesn't deal with immigration and that you look at this completely separately, that's also not true, because you oversee ORR, right? Which is the unaccompanied minor. So how on earth can HHS deal with a tripling, quadrupling of unaccompanied minors coming through your system when you rescind Title 42?
Congressman, once again, by law, we are the entity, ORR, the Office of Refugee Resettlement, which takes a custody of a child that is unaccompanied by an adult found at the border. By law, the Department of Homeland Security cannot hold that child for more than 72 hours. We then provide accommodation.
I understand what your job is. I'm saying
That's
there's
not an
there's
immigration
no
law.
way you can do it under these conditions. I don't care how much money we give you.
We're doing
how many
it.
You're not, though. It's impossible. You're
Congressman, you
letting
understand that
people
Title
go
42
in
has
vast quantities.
Congressman, you understand
That's
that
a
Title
problem.
42, you understand, Congressman, that Title 42 has not applied to those children since
No, I
December
understand that,
2020.
but here's what happens, right? You have an excessive number of people crossing the border, and along with that is more people. They come in large groups. This will happen in by extraordinary numbers without
Gentleman's
Title
time has
42, and
expired.
everybody agrees with that.
Gentleman's
Thank you.
time has expired. The chair now recognizes the gentlewoman from Delaware, Congresswoman Blunt Rochester, for her 5 minutes to question.
Thank you, Madam Chairwoman, and thank you so much, Secretary Becerra, for joining us today to discuss the President's fiscal year 2023 budget for the Department of Health and Human Services. I want to start off by saying that I applaud the administration's efforts to make sure that Americans get health care coverage and also to protect us from this historic pandemic. It is not lost that we have come a long way and we still have a ways to go. But today I'd like to focus on an issue that is really a priority for me and so many others, and the pandemic has exacerbated it. Social challenges have exacerbated this, and I'm extremely pleased to see the administration's budget requests include several important proposals to strengthen access to mental health and substance use care and services. My colleagues on this committee and I have led efforts to provide your department and the Departments of Treasury and Labor with new tools to strengthen the enforcement of existing mental health parity laws. The department's recently released report found that insurance companies are failing and falling short of providing parity in mental health and substance use disorder benefits, and the report documented numerous parity violations. Secretary Becerra, can you briefly discuss the report's findings and why mental health parity is so essential for our constituents?
Congressman, thank you for the focus you've placed on this issue over time, and thank you for the work that you've done. We can't say that we're going to really try to treat with the healthcare needs of Americans if we leave out mental health services, especially at a time when, because of the pandemic, we've seen how dramatically the increase in need for mental health services is out there, and especially for our children. And so we're going to do everything we can to make it clear that the President is willing to invest $50 billion over the next 10 years to change the way we deal with mental health services. And we're going to start doing far more work to aggressively enforce the law to make sure there's compliance with the mental health parity laws that we have in the books.
You know, the fact that some insurance companies are still failing to deliver parity is unacceptable, and that's why I'm really pleased to see the budget request includes funding for grants to help states enforce mental health parity requirements. Can you briefly discuss the challenges that states face in the enforcement and oversight of existing parity laws and why this funding is critical?
As the former Attorney General in the state of California, I will tell you that it is tough. When you have a good partner in the federal government helping you go out there and do some of this enforcement, you can do far more than just the federal government by itself. And so I think many states will appreciate if Congress provides us with this funding, the grant help that will provide states who want to be out there and aggressively enforce these parity laws.
For far too long, frontline workers have lacked access to coverage for mental health, and due to loopholes in the current law that allow state and local plans to opt out of mental health parity. I'm also heartened to see that the budget includes a request to finally close this loophole. Can you discuss the importance of ensuring that frontline workers are protected by mental health parity laws?
Isn't it tragic when you find out that you're working real hard, you're doing everything to keep someone else healthy, and then you don't have access to the kind of care you need? We're going to do everything we can, Congresswoman, to eliminate those kinds of barriers that really don't belong in the 21st century, not in America.
And lastly, Medicaid and CHIP cover 40 million children. Therefore, Medicaid and CHIP investments in access to needed mental health services are critical to addressing the national child mental health emergency. What are you proposing in your budget to specifically address children's mental health challenges under Medicaid and CHIP?
Congressman, we're trying to make sure that first Medicaid is available to all families, and we still have some states that aren't taking up the Medicaid opportunity to provide their families with that care. Secondly, we're trying to make sure that we expand coverage into places in the community setting, so it's not just reimbursement at a hospital, but there's more and more conversation about the possibility that Medicaid could actually be there in schools to provide those kinds of services, mental health services that many of our children need. I've been in conversation with Secretary Cardona in the Department of Education. We're going to continue to work together to see if we can expand access to health care for our children, including in our schools.
First of all, I just want to again thank you so much for this focus. We have experienced individual trauma as well as collective trauma as a country through all of this, and your efforts are going to make a big difference. And thank you so much for being here. I yield back, Madam Chair.
Gentlewoman yields back. The chair now recognizes the gentlewoman from Minnesota, Ms. Craig, for her 5 minutes of questions.
Thank you so much, Madam Chair. Secretary Becerra, thank you for being here today to testify in front of the committee. As a member of Congress, I know that you know one of my top priorities has been to lower the cost of health care for my constituents, a priority that I was so happy to see reflected in HHS's 2023 budget. When discussing the high cost of prescription drugs, those who rely on insulin specifically, we understand why prescription drug reform is so critical. According to the research by RAND Corporation, drug companies charge more for insulin in the United States than in nearly 36 other countries. And the average price in America across all types of insulin was more than 10 times higher than the average price for all the other countries combined. That's why any solution to reduce drug prices must include solutions to reduce the cost of insulin. I'm incredibly pleased that the House recently passed my bill, the Affordable Insulin Now Act, which would cap the out-of-pocket costs for insulin at $35 for those with private health insurance coverage or Medicare Part D. But we know that capping the cost, out-of-pocket cost alone is just not enough. We must continue to work on solutions to effectively lower the list price of life-saving medications like insulin, including through drug price negotiation. So, Secretary Becerra, insulin has been available for roughly a century, and yet the cost that patients face are increasing year after year. In your view, Mr. Secretary, is there any justification for this?
Congresswoman, first, thank you for the work you're doing on this subject. It makes no sense that a drug that's become so readily available continues to increase in price. It shows how broken our system is for drug pricing in this country and why Americans pay far more than most people around the world for the same drug, a drug oftentimes manufactured here in the U.S. I applaud your effort. I hope that you succeed in making it clear that we have to corral these prices and have something that makes sense for the American people. I hope you're able to pass a measure that goes beyond just one particular medicine, because there are so many drugs that are being overpriced here in this country. And so what I can tell you is that no American should not be able to get the drugs they need, and every American should be aware of the effort that you're making to make those drugs much more affordable for them.
Thank you. Thank you so much, Mr. Secretary. I want to just dig in a little bit about your view here. So how do measures already passed by the House, like the insulin bill, such as empowering Medicare to negotiate drug prices, right, inflationary rebates, how do all of those things work together to lower insulin costs? And I'll just follow it up by saying any comments you have on other efforts the administration is undergoing to address the high cost of prescription drugs in America.
Congressman, by opening those curtains to how these drug manufacturers operate and how they price their products, That transparency would give everyone sight on how this is being done, probably not in the best interest of patients. Secondly, we're a country that believes in competition, and it makes no sense that the biggest purchaser of drugs, the U.S. government, whether for Medicare or Medicaid or through the Veterans Administration Program, cannot try to get the best price for all those patients, all those Americans who deserve to have that treatment. And we know that if we're able to get the best price, that we will save Americans not just a lot of money, but will probably add years to their life because they'll be able to afford their medication. 1 of every 3 Americans right now tells us that they skimp on their medication because they have to make it last longer because they don't have enough money to use it the way it's supposed to be used. That's not right. We need to tackle that, and that's where your efforts are going to be indispensable in making it possible for Americans to get the drugs they need.
Mr. Secretary, I'm going to slip in one last question around your directive to CMS to reevaluate the Medicare Part B premium increase. Any updates you can share? I know my constituents really do need the relief.
Congresswoman, that's underway. It's a complicated process, and CMS is working hard so we can give you an answer.
Thank you so much for being before the committee today. I appreciate your leadership and partnership. And with that, Madam Chair, I yield back.
Gentlewoman yields back. Chair is pleased to recognize the gentlewoman from Washington State, Dr. Schreier, to question for 5 minutes.
Thank you, Madam Chair, and thank you, Secretary Becerra, for coming before this committee today to talk about the HHS budget and priorities. First, let me just say, as a pediatrician, I want to thank you for prioritizing children in your budget in so many ways. One thing I'm especially pleased to see is the expansion of the Vaccines for Children program to cover CHIP enrollees. And this aligns with the provisions in the bipartisan bill that I sponsored with Dr. Joyce, Representative Butterfield, and Representative McKinley that strengthens this already excellent and really important program. I was also really happy to see the proposal to improve access for more children by expanding the network of providers who participate in the Vaccines for Children program. And this is really important. We're seeing a drop in routine childhood immunization rates because of COVID. Just last week, it was reported that hundreds of thousands of students are no longer adequately protected from common diseases, used to be common diseases like measles, mumps, and pertussis. And this is particularly dangerous for the tweens in middle school who are particularly behind on their vaccines, where we already see outbreaks of whooping cough. On the topic of immunizations, again, as a pediatrician mom, I know that the best way to help anxious parents feel comfortable about vaccinating their children is a conversation with an empathetic, compassionate, trusted provider. I also know from experience that these conversations take time and that trust is not built overnight. The Medicaid program acknowledged this last summer and is now recognizing the considerable time and effort this can take in a clinic visit and implementing programs to make sure that every person who wants a vaccine can get it. Secretary Becerra, how will HHS work with CDC to ensure that children get caught up on routine childhood vaccinations? And how can we make sure that the pediatricians can take adequate time to have these thoughtful conversations?
Congresswoman, first, you have really pointed out how important it is that those trusted voices that get Americans to take the leap are so essential in this effort. And pediatricians are among the most trusted individuals when it comes to encouraging families to take important measures, safety measures for their children. So we're going to be working with those trusted voices, including folks like you and others, pediatricians, who can really reach out and connect with families in ways that others can't. We're going to continue to make every effort to provide states and local governments with the capacity to do more screening of our families so that they can get the type of information they need. So if we find out they haven't yet received a vaccination, that those families will take the step to let those children be vaccinated. And we're going to try to do everything we can to make sure that under the health programs that the federal government helps administer, Medicare, Medicaid in case of children, and CHIP are available to help those families who have lower incomes be able to include their kids when it comes to the protections that a vaccine provides.
I appreciate that, and I appreciate having multiple locations where kids can get those vaccinations. It also may make sense because those conversations are so long and can take away from other important conversations we have with patients to even have the ability to do a separate visit just regarding vaccines. I also want to highlight your comments about ensuring that Americans have access to affordable health care. And with the help of the American Rescue Plan, there was a dramatic drop in insurance premiums last year. In fact, in my state, nearly 60,000 Washingtonians enrolled in new coverage, and more than 100,000 Washingtonians pay $100 or less every month thanks to these subsidies. And I just want to emphasize how important it is to keep those cost-cutting subsidies and to not let them expire at the end of the year, and also, of course, to expand Medicaid in states that opted out. Is there anything, Secretary Becerra, that Congress can do to work with you to keep healthcare affordable for Americans with the Affordable Care Act plans?
Congressman, I think you mentioned one of the most important things that you can do, and that is to continue those subsidies that have made quality health care. These are robust plans. They're not those skinny junk plans, insurance plans that some people have to buy because they only pay a small amount upfront in premiums, but when they actually end up using the healthcare services, they pay a ton of money out of pocket. And so these plans, as you mentioned, $100 a month in premiums for some families, under $10 a month for other families. It's the way to go. With your help, we can make it possible for more families.
Gentlewoman's time has expired.
Thank you.
The chair now recognizes the gentleman from Georgia, Mr. Carter, for 5 minutes to question.
Thank you, Madam Chair. Mr. Secretary, along with 12 other members of Congress, I sent a letter to you and Commissioner Califf on February 16th about an important issue about blood testing and about the policies and about the American Red Cross. The bacterial mitigation method in question has been implicated in several cases of sepsis and 2 patient deaths. In December, the FDA said that they were investigating more cases. Are you aware of any results of this investigation?
Congressman, I don't know of any final results in that, but we can check back in, or I can have the folks, Dr. Califf and the folks from the FDA get back to you as well.
I would hope so, because this is very concerning to me. As you know, there are 3 different methods that can be used here, and the one that the American Red Cross is using, and they're the primary supplier of blood, is the one that they're using. Not only is it the most expensive of all of them, but it has a shorter shelf life, and we've had these instances of sepsis that have been reported and have resulted in a loss of life. And that's of concern for a number of reasons, particularly in a district like mine, where I have a large rural area. When you don't have a long shelf life on some of these things, then rural hospitals suffer because of it. The longer shelf life, obviously, the better it is for them, and obviously the cost is a factor as well. I'm really concerned about the choice, the hospital's choices being limited, and the customers are only being provided with one bacterial mitigation methodology. And can you understand what my concern here? When the American Red Cross requires that the most expensive, the shortest shelf life, and the one that has been indicated to cause sepsis, that's the only choice they have. Can you understand my concern there?
Absolutely. I hear what you're saying, and certainly I can make sure that we follow up with you, whether it's FDA directly or some other folks in our team. We can try to follow up with you.
I hope so, and I look forward to that because this is extremely important. Mr. Secretary, as you know, I'm a pharmacist and a healthcare professional, and I've been fighting for years to get rid of DIR fees. You know what those are. They're clawback fees. It was put best, I think, by one of my colleagues, Representative Peter Welch. You know, that those DIR fees, the pharmacy may get paid $10, and then 6 months, a year, 2 years later, the insurance company come back and say, well, we should have only paid you $7, so you owe the $3. I mean, that's just not a sustainable business model. And this is what the PBMs have been doing with the DIR fees, and it makes it tough on small businesses and on small pharmacies as well. As you know, pharmacists are the most accessible healthcare professionals in America. 95% of our population lives within 5 miles of a pharmacy. We need to keep pharmacies open. It is important to our healthcare delivery system, accessibility. I was very encouraged that in January, your department proposed a common sense policy that would require price concessions in the Medicare Part D program at the point of sale, where it should be, so that we know it's going to the patient and not to the third party, not to the middleman, the PBM that serves and brings no value whatsoever to the healthcare system, in my opinion. I wanted to make sure, do you agree that your rules, actuary analysis, that seniors would save on net $21.3 billion over the next 10 years?
Congressman, as you know, when we're rulemaking, I have to be very circumspect in what I say, but we stand by what we've produced so far, and we're hoping to issue that final rule very soon.
And I hope that this will go through, and I hope that that you will implement this rule. I've heard some chatter, if you will, some noise that it may be delayed again. I hope that's not the case. This is an actual situation where we can decrease prescription drug costs for patients without inhibiting research and development, without discouraging research and development, but simply by having transparency in the drug pricing chain and making certain that the discounts are at the point of sale where they're going to the patient.
Congressman, I can say it emphatically that we're looking forward to working with you on this issue. And by the way, if you permit me, I'd like to just salute all those pharmacists who've been real heroes in this effort to try to tackle COVID.
Well, thank you. I'm very proud of my profession and very proud of the work that they have done because, as you mentioned, and as I mentioned earlier, most accessible healthcare professionals in America.
They stepped
and extremely important. That's why this issue with PBMs and DR fees needs to be addressed.
Gentleman's time has expired.
And I thank you, and I yield back.
Gentleman's time has expired. The chair recognizes the gentlewoman from Massachusetts, Representative Trahan, for 5 minutes to question, followed by the gentlewoman from Texas, Ms. Fletcher, followed by, and I understand the secretary has agreed to this, the gentleman from Alabama who is waving on, and that will conclude the hearing today, all right? So, Ms. Trahan, you're recognized.
Thank you, Madam. Thank you, Madam Chair. Mr. Secretary, thank you for being here with us today. The FY23 proposed budget indicates that once again, this administration prioritizes expanding affordable, accessible, high-quality health care for all Americans, including those in our underserved communities. In my district in Massachusetts, no one has done more to deliver quality, affordable care to the underserved and under extremely challenging circumstances than the nurses, doctors, and administrators at Lawrence General Hospital in Lawrence, Mass. As you may recall from your visit to Lawrence last August, the hospital serves the 80,000 residents of a beautiful, bustling, diverse, and historic city. And 80% of the city's residents are of Hispanic or Latino descent. And you may remember that the area was struck by a series of natural gas explosions in September 2018, which devastated the community. Just as the city was recovering, the pandemic struck, setting progress back. On a per capita basis, the city has suffered greater numbers of COVID infections than nearly any of the other 350 cities and towns in Massachusetts. And at one point, 3/4 of Lawrence General's inpatient capacity was dedicated to recovering COVID-19 patients. Time and again, Lawrence General has come through for the community, particularly the 20% living in poverty. Indeed, approximately 75% of its patient population is public payer, primarily Medicare and Medicaid. However, by caring for an underserved and COVID-ravaged community, Lawrence General has experienced an unprecedented increase in expenses. And because COVID forced them to pause or postpone more lucrative services, Lawrence General is struggling financially. The proposed budget does not include sufficient targeted funding for our safety net hospitals like Lawrence General, who were particularly hard hit by COVID-19 and now financially unstable. So, Mr. Secretary, I'm just curious how you see the FY23 budget helping hospitals like Lawrence General keep their doors open as they continue to provide critical care to their communities through COVID-19.
Congressman, thank you for the question. And thank you, by the way, for your constant, consistent advocacy for the people in your district who use Lawrence General Hospital, for the workforce, the men and women, healthcare workers at Lawrence, for all the good work that they do as well. We're going to continue to do everything we can, whether it's through the Medicaid program or whether it's through the Medicare program, to provide the services to those, provide the resources to those providers who are out there providing services, especially to our less well-served families throughout the country. I will tell you that as we've had conversations with regard to the Provider Relief Fund that Lawrence and other providers throughout the country were utilizing to try to help cover some of those COVID costs that they had, that we think that it would be a phenomenal opportunity for Congress to provide us with additional resources to supplement the Provider Relief Fund, because it is now essentially out of dollars, so we could continue to provide services and support to those providers who stepped up. And as I've explained to you before, we try to do the distribution of those dollars in a very transparent way. We can't speak for what was done before we came to office, but anytime that we distribute a dollar under the Provider Relief Fund, you'll know exactly how it got distributed.
Well, I appreciate that. I am just curious, the HHS didn't request additional funding for safety net hospitals or provider relief in the COVID supplemental. Could you just speak to, the priorities that were reflected in the supplemental and how we can go about working together so that we do get these safety net hospitals the funds that they need to get through?
Congresswoman, if you look at the original request that we made for a supplemental much earlier this year, we did include funds that would have been made available to the Provider Relief Fund. That request was substantially more than what at this stage is being discussed in negotiations in Congress for a supplemental package. We would love to see dollars included in the supplemental package that would provide additional resources to the Provider Relief Fund. We don't have a vote in that process. It is you and your colleagues here in the House and then in the Senate who will make a decision. But we hope that in your wisdom that you will include funding for the Provider Relief Fund so we can continue to provide those services that those hospitals and other providers have dispensed to many of our uninsured population who need that support.
Thank you. Thank you, Mr. Secretary. I'm out of time. I yield back.
Gentlewoman yields back. The chair recognizes the gentlewoman from Texas, Ms. Fletcher, for her 5 minutes to question.
Thank you, Chairwoman Eshoo, and thank you, Secretary Becerra, for coming today to discuss the President's fiscal year 2023 budget request for the Department of Health and Human Services and its agencies. I have 3 issues I'd like to raise with you in my time today. First, I am thrilled that Congress authorized the Advanced Research Projects Agency Health, ARPA-H, this year, and recent advances in biomedical and health sciences, from immunotherapy to treat cancer to highly effective COVID-19 vaccines, demonstrate the strengths and successes of the U.S. biomedical enterprise. Such advances present an opportunity to revolutionize how we prevent, treat, and even cure rare diseases, including cancer, Alzheimer's, infectious disease, and many others that affect a significant number of Americans and people around the world. Secretary Becerra, in March, you announced that ARPA-H would be part of NIH, but that the physical location would not be at the agency's campus in Maryland. And as my colleagues on this committee have heard many times, I represent many people who work in the Texas Medical Center in Houston, which is the largest medical center in the world and home to some of the most innovative medical research in the world today. The Texas Medical Center is uniquely situated to house ARPA-H with its existing infrastructure, world-leading research institutions, and incredible people. The people who work there are willing and eager to ensure this new agency is successful. So I want to ask you first, when you plan on announcing the location of ARPA-H, and what you're taking into account when making this decision about its location.
Congressman, thank you for your interest and your support for ARPA-H. We are right now in the process of making some of those decisions. We'd like to try to work as closely as we can with the inaugural director of ARPA-H before we launch too far. But what I can tell you is that we wanted to have as much independence as possible, untethered from some of the previous ways that we've done some of the research, because this research we want to be have the applicability as quickly as possible versus some of the basic research that we see that is phenomenal research that is done by NIH. I will tell you that I have duly noted that you've mentioned that there's a great site there in Texas that could accommodate ARPA-H. I will tell you that there are a whole bunch of folks who've reached out to us and told us the same thing. It is a fabulous opportunity for America to launch, just as DARPA for the Department of Defense was able to launch some real innovation. We hope ARPA-H will do the same on healthcare.
Terrific. Thank you so much. I also want to touch on two other issues affecting Texas. Unfortunately, a little bit less positive, but I'm hoping to get your insights here and raise these issues with you. I have raised this first issue directly with CMS. Patients who use Medicaid have been unable to access basic and critical reproductive health care services at Planned Parenthood for almost a year because of the baseless and continued termination of Planned Parenthood from the Texas Medicaid program. It's had a disastrous impact and has really just decreased access to care and led to poor health outcomes. It is a violation of the Medicaid free choice of provider requirement. I saw your exchange with Representative Chu when you testified in front of the Budget Committee, and I look forward to swift action from CMS to enforce this requirement. The second issue I would love to ask you about as well is a similar topic. Really incredibly important component to ensure reproductive autonomy is access to medication abortion, which we know is a safe and effective option in early pregnancy. And now that some of the burdensome risk evaluation mitigation strategy requirements have been eliminated for mifepristone, one of the medicines used during medication abortion care, I want to be sure that HHS is doing everything in its power to protect and expand access to this care, especially in states where there are so many restrictions increasing every day. I really appreciate that you took steps to form the Reproductive Healthcare Access Task Force, and was hoping you could update the committee on the steps that the department and the task force are taking to ensure that medication abortion care continues to be accessible for patients. What specifically is HHS doing to facilitate dispensing and provision of care via clinics, mail order pharmacies, retail pharmacies, mail, and telehealth? I know there are just a few seconds left, but if you could share that with us and prioritize this issue, we would very much appreciate it. Thank you.
Congresswoman, respecting the time that's left, what I can do is follow up with you more specifically, but what I will tell you is when a medication is made available because FDA has decided that it is safe and effective, and we have a job to make sure that we provide care to as many Americans as possible, we're going to do everything we can to enforce the law to make sure everyone, including women, including for abortion care, get the services and the products that, the medical products that they need to be able to exercise their rights.
Thank you so much, Mr. Secretary. I've gone over my time. Madam Chair, I yield back, and thank you for accommodating.
Gentlewoman yields back. Mr. Secretary, I want to ask you to do something. I know that you're 10 minutes past where you want to be. Mr. Palmer is waving on. Mr. Palmer of Alabama. Would you take his questions and then with hearing?
Certainly.
Okay. The gentleman from Alabama is recognized for 5 minutes to question.
Well, thank you, Madam Chair. I truly appreciate your indulgence, Secretary Becerra. I've expressed this concern in other hearings, and I think we're facing a crisis of confidence in our nation, public confidence in many of our institutions. A lot of it has borne out of the handling of COVID. We've become even more divided as a nation, and it's impacting healthcare and the trust in healthcare. And what I want to ask you about, and I hate to do this, but HHS has just issued a Medicare physician's fee schedule final rule that includes a provision that will provide a financial incentive for doctors to create and implement an anti-racism plan. And that's raising a lot of concerns among people. And I just want to hear from you a little bit about how this is going to operate. And I'll tell you my concerns. I think it undermines public confidence in two ways. I think it raises questions in the minds of minorities that if they see a physician who's not of the same race or color, that they're not going to get quality care. And it undermines the confidence of people who are white, that they're going to be discriminated against. How would you address that?
Congressman, I want to be as thoughtful in my answer as you were in the question. First, we don't have a policy as you've described. Our policy is to try to tackle the disparities that we see in healthcare access. I could tell you the number of stories I've heard from women, mostly black women, who go in to get care and they're not believed when they say that they're in pain. There are people who have experienced, who because of sickle cell experience, deep pain when they present at an emergency room, aren't believed and don't get immediately the treatment that really should be provided to someone who's suffering from sickle cell disease. We know that this happens. To ignore it is to ignore a travesty in our system. We're simply trying to say that no one should be denied health care simply because the disparities that exist prevent you from getting the care you need. We're going to try to tackle those the best we can.
Yeah, we already have those rules. And by the way, one of my best friends, Dr. Tim Towns, was one of the leading researchers in the world at the University of Alabama, Birmingham on sickle cell research, and he's white. And he's devoted his entire career to that. And I want you to understand that there is a divide that's being created here that's going to further undermine public confidence. And we have to be extremely, extremely careful about how we address these, all of us, not just the Biden administration, but all of us.
I agree.
And it creates serious concerns that you know, if you go into a doctor's office and you think if you put down you're white, you're going to be.
But Congressman, to that point, if you'll permit me, much of this is driven by the mis and disinformation. I would challenge you to show me where in our policies we call anything we're doing anti-racism policies. We're simply trying to make sure everyone has equal access to health care.
Well, if there are doctors out there that are discriminating against anybody for any reason, they need to be dealt with in another manner, because that is totally unacceptable. Totally unacceptable.
Agree with you.
So I just want to raise that point, let you know that this is an issue. There are people out there that have raised concerns to me about it, and I intend to address it further at the appropriate time. But I do appreciate very much you answering the question and your assurances that it is not the intent of HHS to discriminate against anyone. I will hold you to that. And also, again, I sincerely appreciate you staying 30 minutes past the original time that you said you'd give us. And with that, Madam Chairman, I will yield the remainder of my time.
The gentleman yields back the remainder of his time. And Mr. Secretary, thank you for accommodating the members and the member that has that waved on and that you would take their questions. It's very generous of you. Thank you for being here today. We've covered a lot of ground. I would just quickly raise 2 points, Mr. Secretary. You're a former member of Congress. You know that you wanted your questions answered when you addressed those that were representing agencies. I think the Assistant Secretary of Legislation has some work to do, some catch-up work here, because on both sides of the aisle, members have made reference to writing, but they haven't had their questions answered. And secondly, I think that it's important, as Secretary of HHS, to have a plan if, in fact, Title 42 is lifted. You have responsibility for a plan, a public health plan, so that there is not any public health disaster relative to those at the border. So that is your responsibility. I know that 42 seems to be kind of up for grabs right now because of the court case. But nonetheless, HHS has to have a plan. I don't know what that plan is, but I expect that you would come out with one and outline it. So,
And Madam Chair, on
thank you.
that point,
Yes.
if you're referring to the situation at the border, we do have a plan to address that situation post Title 42. If you're speaking more generally in terms of what happens to the country without Title 42, we have been working on that as well, and we could present that to you and the committee members if you'd like.
No, it was the former, not the latter.
Yeah. And remember, Madam Chair, that Title 42 has not applied to the individuals at the border that HHS has jurisdiction over, the children. We haven't had Title 42 apply to unaccompanied migrant children since December of 2020.
Anyone that comes into the country that is admitted into the country, there are public health issues there. And we've had to deal with them before, and we might be presented with that case. I don't know, given the courts or what the administration is going to do. But you always have to have a plan, and I don't think we can walk away from that. All right, I just have a unanimous consent request to enter 2 items into the record. Does the
No objection.
No objections. So without objection, so ordered. Members have 10 business days to submit additional questions for the record and the witness. We ask that the secretary respond promptly to any questions that are received. And at this time, the subcommittee is adjourned. you.